कि मैं क्लिनिक करती हूँ, बट आई विल ट्राई, पूरा मैं कोशिश करूंगी।
मेरी मैं सोच रही हूँ आइंदा से अमृता किसी इलाहाबाद वाली को भेज दिया करो, लड़की को।
हम जब मैम कहते हैं तो मैं जरूर भेज देती हूँ, कई बार वो मना कर देती है कि नहीं नहीं मैं ज्वाइन कर लूंगी।
श्योर श्योर, ओके ओके, नो प्रॉब्लम, नो प्रॉब्लम।
Shall I start, Ranjit ji?
Yes.
Just a sec, ma'am.
Okay, please give me a countdown, 3, 2, 1, then I'll start.
Right. So, ma'am, I will start it, then hand over to you. Is it fine, ma'am?
Yes, आप कर दीजिए जैसे आप करेंगे.
So we are live on YouTube as well as live on Zoom. The delegates have started entering. So this is Ranjit Sahu, Marketing Head with Walter Bushnell. Welcomes you all. This is a lively webinar on where UPCOG in association with Foxy Gynecology Oncology Committee present you a live webinar on a date with colposcopy. So we have esteemed delegates from across UP and across the country who have joined for this lively webinar. So with this, I hand over to ma'am to take it forward. Over to you, ma'am.
Thank you so much. शुभ संध्या, हार्दिक अभिनंदन, आप सभी को मेरा करबद्ध नमन। मैं हूँ डॉक्टर प्रतिमा वर्मा, असिस्टेंट प्रोफेसर जीएसवे मेडिकल कॉलेज, आज के कार्यक्रम की संयोजिका। इस अति महत्वपूर्ण कार्यक्रम का प्रारंभ में एक अति सुंदर श्लोक से करना चाहूंगी। न चोरहार्यम न च राजहार्यम न भ्रात भाज्यम न च भारकारी वे कृते वर्तते एवं नित्यम विद्याधनम सर्वधन प्रधानम। इस विद्या रूपी ज्ञान के दीपक का प्रज्वलन कर आज के कार्यक्रम को आगे बढ़ाते हुए मैं वॉल्टर बुशनल की टेक्निकल टीम से ऑनलाइन दीप प्रज्वलन के लिए अनुरोध करना चाहूंगी तथा गणमान्य अतिथियों से इस ऑनलाइन दीप प्रज्वलन में प्रतिभाग के लिए अनुरोध करूंगी। प्लीज प्ले द वीडियो।
कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः।
Thank you. On this auspicious evening, I would like to invite our chairperson, Oncology Committee, a perfect blend of beauty, brain, perfection, and intelligence, none other than Professor and Head of Department, Professor Dr. Kiran Pandey, ma'am, for welcome address.
Good evening, everybody. Namaskar. मेरे सभी जो यहाँ पे बहुत ही डिग्निटरीज, सीनियर्स, उन सबको बहुत बहुत शुभकामनाएं आज के इस प्रोग्राम के लिए। और in the capacity of chairperson oncology committee UPCOG, it is my proud privilege to welcome all these stalwarts of UPCOG at this reputed platform. As we know that prevention is always better than cure. So considering rising of cervical cancer cases, still we have to rise and stand under the leadership of our esteemed patrons. As we all know, our 2030 goals are 90, 70, 90, which means 90% of women are fully vaccinated against cervical cancer at the age of 15. 70% of women are screened for cervical cancer by the age of 35 to 45, and cervical, by the age of the 90% of women with positive cervical screening have received the treatment. So the same is the reason we are here, and the role of the colposcopy cannot be overemphasized in prevention of cancer cervix, yet it is underused. So that is why we have selected this topic. And here we present a live webinar, a date for colposcopy. So warm welcome to our honorable and scholarly personalities, Padam Shri Professor Raj Babeja ji. She is the Chief Advisor of UPCOG. I welcome our respected, magnanimous personality, Chief Patron Padam Shri, Professor Dr. Usha Sharma ji, dedicated personality, Professor Dr. Chandravati, patron UPCOG, the dynamic magnetic personality, Dr. Meera Agnihotri, patron UPCOG, for your warm presence. And I extend my heartfelt welcome to our talented President UPCOG, Dr. Tarni Taneja, kind-hearted and very dedicated Secretary, Dr. Kirti Dubey, the Dr. Bharati Maheshwari, a very dedicated personality for UPCOG, working even during her illness. Her commitment is unparalleled. Affectionate Dr. Archana Verma, Vice President, very pleasant personality. Dr. Priya Ganesh, the Chairperson, FOXY, Gynecologic Oncology Committee, FOXY, for playing a pivotal role in cancer cervix prevention. And special thanks to our shining personality, Dr. Sadhna Gupta, the Director, Jeevan Jyoti Hospital, Gorakhpur, Dr. Neelam Mishra, President IMA Kanpur, and past President Cox, Dr. Urmila Singh, my co-chairperson, along with me. And I just to name with it, because they will be introduced formally later on, the esteemed panelists, Dr. Amrita Chaurasia, Dr. Sapna Singh, Dr. Kiran Sinha, Dr. Parul, Dr. Priyanka, Dr. Pragati. So warm welcome to all of you for your sharing the knowledge at this platform. Dr. Sapna will be conducting the slogan and poster competition program. And for esteemed judges are Dr. Seema Hakim, Professor at AM Aligarh, Dr. Sujata Dev, Professor KGMC. So welcome once again to all of the dignitaries. And to save the time, I will stop myself here and hand over the mic to Dr. Pratima to invite all the dignitaries.
धन्यवाद मैम. गुरु ना प्राप्यते यत् ना अन्यत्रापि ही लभ्यते. गुरु प्रसादात् सर्वतु प्राप्तो अप्राप्येत ना संशया. अपने बीच उपस्थित सभी गुरुजनों का मैं हार्दिक अभिनंदन करती हूँ, क्योंकि गुरु की कृपा के बिना तो कुछ भी संभव नहीं, और गुरु की कृपा से अप्राप्य भी प्राप्य हो जाता है. I am privileged to be part of this wonderful webinar, which is a star-studded galaxy of Obs and Gynae. First of all, I would like to request our chief guest, a charming and intellectual personality, a great teacher and advisor of UPCOG, Professor Dr. Raj Paveja ma'am, for a few words of blessing. Ma'am.
Pratima ma'am has joined or not, just check it. Otherwise, whenever she joins, you can call her.
Okay, ma'am.
मेरे ख्याल में दिख नहीं रही है राज जी.
तो मैम हम लोग जब वो ज्वाइन करेंगे तब उनसे दो वर्ड्स कह लेंगे.
वो बाद में भी कर लेंगे. ठीक है.
जी 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 जी. आप
यथा नामा तथा कर्मा. जी हाँ, मैं अब निवेदन करना चाहूंगी. हमारे बीच उपस्थित एक अद्वितीय अद्भुत व्यक्तित्व जो ज्ञान रूपी किरणों से सभी को संचित करती हैं. पद्मश्री प्रोफेसर डॉक्टर उषा शर्मा मैम, चीफ पैट्रन यूपीसीओजी. मैम कृपया अपने आशीष वचनों से इस कार्यक्रम को आगे बढ़ाएं.
Thank you very much, Pratima, for very sweet and kind words. All of us know we have with us Chief Advisor Dr. Raj Paveja and our very loving, affectionate leader Dr. Chandravati, my great support Dr. Meera Agnihotri, and then it is very pleasant to have North Zone Vice President Dr. Archana Verma as guest of honor with us. And then certainly we know that Kiran has organized this, and we have a wonderful speaker, none other than Dr. Priya Ganesh, who is a real instrumental person in creating and spreading awareness regarding the cancer cervix. And she has always been so energetic that whenever she conducts any webinar, she leaves no stone unturned and telling us very good things for the prevention of cancer cervix. As just now Kiran said, we all know that WHO has declared the statement mission of cancer cervix eradication by 2030. And so it is our duty to just join hands and to do our best for the prevention of cancer cervix and even for the treatment of cancer cervix. And today we have the webinar on colposcopy, as well as we are going to have a talk on pre-invasive carcinoma treatment. And then we have a slogan and poster competition. We have with us many dignitaries like Sadhana and Neelma, and then I said Archana Verma and Urmila Singh, and very, very learned and worthy panelists with us. So what I feel that this subject is a very good subject, and let us join hands to make this dream of cancer cervix free, Mukt Bharat, come true. And if we are together, I'm sure we can do it. With these words, I wish this program a great success, and I'm sure that the deliberation today will go a long way in updating the knowledge of every one of us. Thank you very much for making me a part of such a prestigious program. God bless you all.
Thank you so much, ma'am, for your words of wisdom. It's time to invite another charismatic personality who has been a constant source of inspiration and dedication, none other than Padam Shri Professor Dr. Chandravati ma'am, a patron UPCOG. Ma'am, please bless us with your kind words.
Thank you, Pratima. I think first thing is your Hindi is so beautiful. I think we should have taken Hindi as a subject. It is very, very sweet to listen to your ways of presenting people. It's a real pleasure. Secondly, you have given me a compliment, which probably I don't have, but it is nice to hear it. I'm very, very happy for this webinar because the subject you people have chosen is very, very dear to my heart. I fully believe in screening and vaccination to prevent cancer cervix in our women. And I think if we really are the whole gynae women, we doctors are together and we give real time for screening, and at the same time take some time out to explain the women, girls, for early vaccination against cancer cervix, I think we will go a long way to protect our women from this deadly disease, which is now preventable, curable, everything it is there. You'll be surprised to know that I have been screening my women with pap smear, HPV, when needed colposcopy, combined with vaccination. And for last 5 to 6 years, none of my patients who have been with us have come out with cancer cervix. So I think it is a wonderful subject. I thoroughly would enjoy listening to people, and the topic chosen are wonderful. Usha has already said there are great people who are as orators, as a panelist, and we will all enjoy it. God bless you. I wish success to this seminar and success to all the people who have come forward from Kanpur to organize this webinar. Thank you. Kiran, best of luck.
Thank you, ma'am, for your
Thank you, madam.
Great
Thank you, madam.
congratulations.
Thank you.
Kiran, great congratulations to you and your team.
Thank you, madam. Thank you, madam. Thank you, madam.
बढ़िया बढ़िया लड़कियां चुन के लाती है कॉलेज की, अपनी बढ़िया से बोलती हैं,
खुद
सुन के
बढ़िया
अच्छा
है ना
लगता है।
मैडम,
मैम
आप लोग
का
का
फैक्ट है।
आशीर्वाद है, हम लोग छोटे हैं, हम लोग की गलतियों को माफ करिएगा।
अरे गलती हो ही नहीं
कोई
सकती,
गलती नहीं यार,
हो
कोई
सकती
गलती
नहीं। थैंक यू लवली किरण, वेरी नाइस।
Thank you. Thank you.
Thank you, Chandravati ma'am. You're really a charismatic personality. When I was a kid as an MBBS, then I used to know Chandravati ma'am. So ma'am, please, you have been a source of inspiration. That's why I use these words. My personal experience.
Thank you.
Now it's time to invite a majestic, marvelous personality who has been working untiringly for betterment of women health. None other than our Professor Meera Agnihotri ma'am, patron UPCOG. Ma'am, please give your words of blessings.
Thank you very much for your lovely words. It's a real honor to share the dais with Usha ji, Chandra ji, and Archana, Dr. Raj Baveja. All of them are so great, so I'm feeling honored. At the outset, I congratulate the chairperson of the Oncology Committee of the UPCOG, Dr. Kiran Pandey, for organizing a fabulous webinar today. Although it is quite lengthy, I believe it will be completed in time. Kiran, the speaker chosen by you, is just a wonderful person. I've been working with her. I've presented many meetings with her, Priya Ganesh, and she must also be remembering me. And I really congratulate you for this subject. The main mission of our country and Honorable Prime Minister is Cancer Mukt Bharat, Corona Mukt Bharat, and Poshan Yukt Bharat. So for Cancer Mukt Bharat, this was one of the important subjects. And I also know that we are fully aware that prevention and vaccination are the two tools balancing each other to come out of the crisis and to reduce the number. So you will be talking about the screening also and vaccination. Dr. Chandravati and myself, we have been instrumental in getting these vaccines when they were discussed in very infancy of the life, whether to be given, not to be given. Somebody has reported a death and so on, but it was coincidental. Now,
कुछ प्रॉब्लम हो गई किरण, कुछ प्रॉब्लम हो गई शायद, या मेरे में नहीं आ रही आवाज, आ रही है?
नहीं,
वॉइस नहीं आ रही है मैम।
आई थिंक उनका नेट।
चलो आगे बढ़ जाओ फिर।
ठीक है।
Yes, ma'am. Now I would like to request adorable, affectionate, and awesome Vice President of Foxy, Dr. Archana Verma, ma'am. Ma'am, please bless us with your kind.
Am I audible? Thank you very much.
Yes, ma'am. Yes, ma'am.
So Kiran, you just continue. I believe I am able to convey that Kiran is working with Indian Institute of Technology for Cancer Cervix, and that agenda of her is passed in the last ethical committee meeting. I think she will come out with great things, and Priya Ganesh will be sharing it. Thank you very much once again, Usha ji, Chandra ji, and I believe Raj ji has come or not. My regards to them. Thank you very much.
Ji, thank you.
Thank you so much,
thank you
for your kind words. Now it's time to invite adorable, affectionate, and awesome Vice President of Foxy, Dr. Archana Verma, ma'am. Ma'am, please bless us with your kind words.
Thank you, and thank you. You know, right from my so much of my early days, I would like to say, एक ही तमन्ना थी कभी यूपी सीओजी में तीनों लोगों को एक साथ मिल सकूं, चंद्रावती मैडम, मीरा अग्निहोत्री और सबसे बड़ी हमारी उषा शर्मा मैडम। मतलब जितनी शिद्दत से मैंने पाने की कोशिश की थी, उतनी ही शिद्दत से भगवान ने मुझे इनसे मिलाने की साजिश भी की। एंड आई एम सो हैप्पी. Or I really my good wishes to Dr. Kiran Pandey madam, and my respect to Dr. Raj Baweja madam and all the seniors, Dr. Kirti madam, and she's a really like very simply the best senior. Dr. Kiran, Dr. Tarni madam, our UPCOG dynamic president nowadays, and Pratima Mittal, तुम्हारी अभी बहुत तारीफ हो गई है, so I think I must say yes, wonderful. And this cancer awareness is really, awareness is my passion. I really love, and I ask every gynecologist to run for marks 90, 70, 90. Don't even think less. So if we are able to go and reach there, it will be wonderful. And then today is a great program. All the speakers will be doing the justice. Dr. Kiran Pandey has arranged a wonderful party of wonderful speakers, all the stalwarts, and not to miss even a single second. And I'm really, really honored to come here. Thank you, Madam Kiran, madam.
Thank you, Dr. Archana, for being here.
Thank you so much, ma'am. Now I would like to request.
1 minute, Dr. Sadhna madam also I can see, and yes. Thank you and welcome, madam.
Actually, we have very strong pillars like Tarni Taneja and Kirti Dubey and Bharti Maheshwari and UPC.
Oh, Dr. Bharti and Dr. Kirti. Yes, I'm very sorry.
नहीं,
मैडम मेरे को भी ना आपके साथ ही रहना है। डॉक्टर मीरा अग्निहोत्री मैडम, मुझे ना वाइस प्रेसिडेंट मत बोला करो, मैं यूपीसीओजी की हूँ, मुझे तारनी के आसपास लपेट दो कहीं।
Thank you, ma'am. Now it's time to invite charming, dynamic, energetic, and enthusiastic President of UPCOG, Dr. Tarni Taneja, ma'am. Ma'am, please bless us with your words.
Thank you so much, Pratima, for your lovely words. First of all, the greetings on behalf of PPCOG. Namaste to everyone. and to all the our honorable senior Padma Shri Raj Bhaveda ji, Padma Shri dynamic guiding force to everyone. जितना कहो वो कह दे. Usha ma'am, Chandra ma'am, Meera ma'am, they are icon of infertility for women wellness. So they are versatile. चांद सूरज सितारे कम चमकते हैं जितनी कि हमारी मैम चमकती हैं. आई विश कि ऐसे ही वो चमकती रहे, हमें ब्लेस करती रहे. आई एम रियली हैप्पी टू बी एसोसिएटेड विद ऑल ऑफ देम, ऑल ऑफ मेंबर्स. So on dear friends, and Dr. Priya Ganesh as a speaker, my beloved friend Dr. Archana Verma, and very dynamic secretary Dr. Kirti Dubey, Dr. Bharti Maheshwari. She is a very versatile, hardworking. So actually, at this outset, I would like to congratulate the chairperson of the UPCOG Oncology Committee and our Vice President and gorgeous Dr. Kiran Pandey for choosing such an important practical practice subject. Everybody has said for that. But I really like the title, A Date with the Colposcopy. So I was just laughing. Still we are dating with the colposcopy. You know, we have developed so much in all the segment, endoscopy, infertility, fetal medicine. Kaam ja rahe hain. So still dating with the colposcopy since 1935. Since the German scientist Selman described as a screening tool. So what are the reason? I think Dr. Priya will tell in detail, but I know because since the findings are subjective and there was no guidelines and recommendation, maybe because that was the underuse. So now, what is the significance? Is a very good diagnostic tool to diagnose these precancerous and cancerous lesion. What is the important in this? Because it's good magnification. Maybe we can use 10x or till 18x. And there is also green filter that can pick up the basal abnormality in the form of the mosaic, punctation, whatever we cannot see on the acetovite. So that is the good point of the this colposcopy. And it is also be used for the localized, for the mapping the extent, for colposcopy. So details I would like to learn from the Priya ji. And now clinicians, since the American guidelines have come, American Association of the Colposcopy and this cervical pathology. So they have given the a recommendation for the procedure and also for the documentation. So I was just elaborate the one line. They say we should do the grossly examination of the vulva, vagina and the cervix before putting any resin in the natural light, and then after putting the acetic acid or lugol, whatever we want, we should examine under the green filter, and also we should evaluate for the squamo-columnar junction in detail. And what they say, for the adequate colposcopy, documentation is very important. It should be impression in the form of, it should be in the low grade or high grade lesions, along with the veins and the suede scope. So since the cervical cancers are very progressive, it takes many times 5 to 15 years to become the invasive cancer. So whenever detected early and treated in timely, it can be prevented very well. 100% cure is there. So thank you so much, Dr. Kiran. Congratulations again for such an important topic. We would like more lessons from the Priya, where we should use in the S-curve and when the abnormal pap smear. So details we would like to listen later. So thank you so much for giving the opportunity. Thanks.
Thank you.
My regards to Dr. Sadhana. She is here. Dr. Sapok, representative, or probably the candidate for presidentship here.
Yes.
And all my, friends and senior, my regards, and thank you so much, everyone. And Dr. Archana Verma, I think I have spoken to Dr. Archana Verma, beloved friend Dr. Archana Verma. Okay.
Thank you, ma'am, for your lovely words. I am honored to invite my own mentor, kind-hearted, youthful, benevolent, and approachable personality, Professor Dr. Kirti Dubey, ma'am. Secretary UPCOG, ma'am, please bless us. Ma'am?
Unmute kar lo, Kirti.
जी मैडम, Good evening, everybody. Am I audible now?
Yes,
Yes,
yes, yes.
ma'am.
Good evening, everybody. And first of all, I would like to thank Pratima for speaking such kind words for me. And thank you, Kiran, for making me a part of this webinar. And pranam to my gurus, Usha ji, Chandra ji, Meera ji, and all regards to my seniors. I don't want to waste time. I think everybody wants to hear Dr. Priya, of course, as early as possible. I have just a line to say that the Western world has put endometrial carcinoma as the commonest malignancy. But we Indians are still lagging behind, saying that it is carcinoma cervix which comes out to be the first malignancy of the genital tract. Let all of us become aware. Let all of us aware our patients, do all investigations, do all preventive measures of vaccination, screening, and make this carcinoma cervix not the first, but let it be also number 3 or 4th of genital malignancies.
Yes, yes.
Thank you so much. And of course, we are here anxious to hear about colposcopy date with colposcopy. And we are here, Pratima. And one thing, madam, I would like to tell you all, Pratima has been an LLRmite here at Meerut.
Oh.
And she was such a good postgraduate we had. And such beautiful Hindi she has, madam. And I remember I was to address at 15th August and 2nd October. And it was she who wrote such a beautiful language that I could not forgettable. And Pratima, I've kept it with me. I have that. I have that.
Very good, very good.
Thank you,
So-
Kirti. Pratima,
so I
Dr.
think
Baveja
Kiran-
has joined. Dr. Baveja has joined, madam.
Acha, 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 acha.
Just a word, Dr.
हाँ,
Baveja.
sure,
then we
sure,
start.
sure.
Then we start.
Sure,
Now I would like to request a charming and intellectual personality, a great teacher, advisor of UPCOG, Dr. Raj Baveja ma'am, for words of blessing. Ma'am.
किसी की बीच में आवाज आ रही है, प्लीज.
Raj Baveja.
राज जी.
Yes.
नमस्कार राज जी.
I'm here on the seashore.
Yes.
I'm here on the seashore, giving all my blessings to everybody, to all my teachers, and to everybody I respect as my gurus, because I've learned everything.
No, you are our guru.
Or from Usha ji, and also Kishore, who has been my even examiner. I bow my head down to Dr. Junior, Dr. Kutti, Dr. Mukherjee, everybody from KGMC. And I bow down to even my own people who are working with me at the moment, and also who have been now the head of the department of various colleges. God bless everybody. And I'm very happy to join today because I could manage it. Thank you so much, Usha ji.
Thank you, Raji.
Thank
We
you, madam.
Your blessings, Raji.
I am not forgetting her also, because I know she's sitting somewhere over there. Thank you so much.
Thank you, madam. Thank you.
I'm very happy to join here. And
मैम आप unmute करिए.
Girl who rang me up this morning.
अरे मैंने आवाज लगाई था राजी को.
Where are you? I can't see you.
अरे ये दिख रही हूँ.
नहीं, आपकी फोटो आ रही है, जा रही है.
अरे मेरा फोटो
आ गई.
किरण ने कुछ गड़बड़ की है.
नहीं मैडम,
इसकी इतनी जरूरत नहीं है.
मैडम मैं ऐसा कैसे कर सकती हूँ? आपकी स्टूडेंट रही हूँ, आपसे सीखा है. आपकी
So I think Kiran, now let us have date with colposcopy with our very charming, beautiful and a wonderful orator, Dr. Priya Ganesh.
Pratima, please invite Dr. Priya.
Yes, ma'am. Now I would like to invite a phenomenal personality, Dr. Priya Ganesh, ma'am, Chairperson Foxy Gynecology Committee. Ma'am, please bless us with words of wisdom.
And also invite her for a lecture also.
then ma'am, first of all, I have to introduce chairpersons also, ma'am.
अच्छा ठीक है.
Yes, ma'am.
नमस्कार मैडम, यहीं से आप लोगों को सबको साष्टांग नमस्कार. And I'm really feeling proud and honored and privileged to be in with UP COG. यहाँ की देवियाँ, मैडम, 3 देवियाँ मेरी खुद की माएँ जैसी हैं मैडम. हम लोग माँ को प्रणाम करते हैं आशीर्वाद लेने के लिए. उसी प्रकार आप तीनों देवियों को मेरी आशीर्वाद मैडम, आशीर्वाद क्या कह रही हूँ मैडम, आपकी आशीर्वाद मुझे लगे. So that's the major thing, ma'am, and I'm really honored. When Dr. Kiran Pandey had called me up and said, "क्या topic रखें, madam?" and I was really like so happy because उसी time, madam, if you remember, SSNPP वाली screening वाली program हुई थी अपनी UP के साथ. तो मैंने सोचा कि अब ये होगा कि a date with Colposcopy. ये होना चाहिए ताकि तब हमें जब स्क्रीनिंग करके बाहर आए स्क्रीन पॉजिटिव क्या करें, and then when we go with a colposcopy, and that is where we really fumble, and sometimes that reporting interpretations में कहीं ना कहीं 19-20 हो जाती है, and then we really don't know what to go ahead with. So that was the thing.
और तुमने सोचा होगा प्रिया एक्चुअली कि एकेडमिक को जरा रोमांटिक बना दिया जाए.
रोमांटिक मैं गाती रहती हूँ. ट्रू मैडम, और आपको देखकर तो आप लोगों को मीरा मैडम, आप इतनी सुंदर हैं तो आपको क्या बताएं, आपको देखकर आज भी रोमांस किसी को आ जाए. मैडम, छोटी मुंह बड़ी बात. बट
उषा जी, इससे बड़ा कमेंट कोई नहीं हो सकता कि इस उम्र में भी हम लोग रोमांस कर सकते हैं.
बिल्कुल, क्यों नहीं. ये तुमने क्या कहा, रोमांस के लिए कोई उम्र नहीं होती.
I know.
किरण, सॉरी, हमने टाइम वेस्ट कर दिया तुम्हारा थोड़ा.
नहीं मैडम.
So thank you मैडम.
मैडम, आप लोग की बात सुन के हम लोग को भी थोड़ा रिजुविनेशन होता है.
मैं तो आज बहुत डरते बोल रही थी कि मैंने किरण से खुद कहा है कि सब कम बोले.
मैडम, कम होता ही नहीं है. जब आप लोग आ जाते हो, मीरा मैडम, आप, चंद्रावती मैडम, कहाँ से मुंह बंद होता है. हमेशा कॉम्प्लीमेंट करने के लिए ही फिर मुंह तरसता है. So thank you very much, and I'm always there with UPCOG, madam.
प्रतिमा, आप इनवाइट कर लीजिए अब चेयरपर्सन्स को, so that we start the academic meeting.
Yes, sir. Thank you all dignitaries for your blessings, and now we have to move ahead for our scientific session. For this, I would like to invite our chairperson, Dr. Sadhna ma'am, Dr. Neelam Mishra ma'am. Dr. Sadhna Gupta ma'am, an amazing, unique, and unparalleled personality working sincerely and selflessly for benefit of humanity. She is director of Jimny Infertility Center, Gorakhpur, and she is the ideal candidate for president of UPCOG. Best wishes, ma'am. And Neelam Mishra, ma'am, a noble and compassionate president of IMA Kanpur. Now I would like to request Sadhna ma'am. Ma'am, please introduce our speaker. Sadhna ma'am.
Thank you. It is actually, first of all, my sincere and heartfelt regards to Dr. Usha Sharma, Dr. Meera Agnihotri, Madam Chandravati, all beloved persons, Archana Verma, Tarini Taneja, and Dr. Kirti is also senior, Dr. Bharti Maheshwari, and everybody from UPCOG. So it is our own state chapter, and it is a really, we have so much. I think this is one state that really where we are connected to each other. In very few states that we have got that seniority, juniority, and that sort of connectivity. So we have to be like proud of this very strong relationship, and we also set forward for many like targets for women's health, because UP has got its own issues with high population, as well as the people who are dedicated, who are tough, and who have got a lot of positivity. So as a state UP chapter, we have to go together for a long way. And my hearty thanks to Dr. Kiran Pandey for this wonderfully crafted program, and for the invite and opportunity once again to be with our mentors, with our teachers, seniors, and the beloved friends, as well as the juniors. So coming to the, like what we can say, the date with colposcopy, and it is a really pleasure to have Dr. Priya Ganesh Kumar, and we have met just few days ago for quite a good time in Bombay, and she has, like, even in her election process, and I like it also that the election process should not be a fight. Election process
must be the purification processes, and for like coming our ways with the commitment with our own ways. And Priya, in her election process when she was contesting for it, actually proved that, and that really drew my deep interest in Priya, because we need people like Priya as a chairperson in Foxy. So it is a pleasure to invite Dr. Priya, who has taken over in June Foxy Oncology Committee chairperson. She has been medical director of Sainiva's chain of preventive oncology centers pan India. She has a lot of publication and the books authored, and has been awarded with many awards like National Award, G Hindustan Swasthya Award, Thane Gaurav Mayor Award, Economic Times Award, IMA Excellence, and Wonder Foxian Award. And she has been the ex-HOD Preventive Oncology Department, CR Wadia, and ex-PCPD and the chairperson, Thane District. So Dr. Priya is one of the, I think, yes. So her subject is colposcopy, and we have been through her like keen interest and her like a unique to her teaching, that she takes very simple thing and she clears the doubt to everyone whosoever is doing colposcopy. And it is what as a UPCOG, I remember when we invited Dr. Usha Saraiya once upon a time in like deep winters in Gorakhpur for IMA oration on preventive oncology, and I still remember where the story should end, that is CIN. And she said about colposcopy, and that time it was a simple magnification camera. Now we are having video colposcopy. Now we are having mobile colposcope. So the technique is changing, our observation is changing, and what is out that the technique is changing to the people who are not in the reach of the high technology. So this is the charisma of today's technology, that with the mobile, with the cameras, we can have the tele-consultation, we can do colposcopy simple with mobile phone, even in rural areas in our camps. So we are really looking forward to listening to Dr. Priya Ganeshan, and it is always we have to be very observant in colposcopic finding, and I am also looking forward for a keen observation of all her colposcopy pictures, because it needs revision, and update. It requires observation, not a loads of knowledge. So welcome, Priya. We are really looking forward to hear you once again for on the date with colposcopy. Over to Priya.
Yes, madam. Thanks a lot. And I am over here, ma'am, with you. I'm humbled and honored to have you, ma'am, as my chairperson, because I've always been your strong, admirer. So there I am, ma'am. Thanks a lot. And coming up with the topic is optimizing colposcopy reporting and interpretation. This is somewhere what I thought was, let us name this as reporting and interpretation is something, because people know the steps very well. But then where we really go into some certain mistakes. So there I am today. Let's see how I can really do justice to the topic given to me. So I bring greetings from my Mumbai center. The scope of these lectures will be to have terminologies understood. We all know the terminologies, we all are professors, and we all are in a very honored post. But I thought when we start colposcopy, it's always better we start from the scratch and then go by building up till the interpretations. Then I'm going to get to you all a colposcopy procedure with a video, how effective should be the methodology of doing a colposcopy. I'm also coming up with an IFCPC classification for reporting and what is the sweet scoring. And then I have not put the bullet points, few more, is what do we do on a screen and treat, and what is see and treat. So there I am with this topic. So vision is the art of seeing what is invisible to others. That's what colposcopy makes our life easier to understand. So here the cancer is shouting at the top of his voice saying, you know me. But here we are, madam, we look at here. We have, dear friends, 10 times to 12 times more of precancerous conditions compared to a cancer. So when we say that India is having, we are second in the globe or in cancer deaths, how many pre-cancers we have missed out. And that's the actual tragedy. The biggest tragedy is we have missed out this, so that this has erupted and shown its head above the neck of water. when we talk about cervix, if I have to put it up into 4 quadrants, this is normal, this is cancer. Obviously, you don't require a major skill to understand cancer because the histopathology does its major job. You see it even a general practitioner, when they see the put the cuscos and see a growth, the first thing which comes into their mind is cancer. Then the DDs come as tuberculosis or something else. So the cancer is quite easy, I would say. But when it comes to a precancerous condition, this is the time, and it's occupying almost 2/4, that is half of the cervix, whereby we as gynecologists, we all are preventive oncologists. So this is where we'll have to pick it up, because, and we have been talking about 90, 70, 90, now so far, so forth. We know about this. So that is like, if we can identify by a secondary prevention by doing a colposcopy, screen positive, we know we have cafeteria approach of VIA, HPV, PAP test, all that thing is fine. We get a bundle where we say this is a cohort which are screen positive. Now what next? That's what next is, not hysterectomy. Because normally what is happening is people have been running for, whenever certain screen positive comes up, is hysterectomy is the first question, first answer which comes out of their mouth. So it's not the hysterectomy. It's like identifying what are the types of CIN which we are looking at, and can we really do a better job to prevent this CIN from getting into cervical cancer. So that's the part. And so we are over here in the green zone. We still are in the green zone. We can do wonders. Believe me, dear friends, we can do truly wonders. When we detect this CIN, we treat them with the local techniques and then say that they are cured and keep them under follow-up so that we don't go into the red zone. So now talking about the terminologies, since we have college students also, PG students also, so I'm quickly taking you all, not wasting much time. Like squamous, and I'll be giving you the importance of why am I taking these terminologies. When we talk about epithelium, we have squamous and columnar. Squamous epithelium, multiple layered, that is why it looks pink in color, not red in color. It's not in a straight line. The basement membrane is thrown into folds, and hence you have the stromal papillae, and you do have those the blood vessels entering into it. The cut section of these blood vessels are the basics of understanding punctations. You have this columnar epithelium. Now this is a single layered epithelium, so it looks red in color, which is thrown into folds, and hence it looks granular. When you look at a cervix, the columnar epithelium, which is red color, looks velvety. Why? Because it is thrown into folds. And also the other significance is when this crypt opening, and they are understood by crypt opening. Now, the most distal crypt opening gives us an understanding of SCJ, the distant STJ. Now, whenever there is a crypt opening getting closed, it is a penting of those, secretions giving rise to Nibothian. Now, once as a colposcopist, you are supposed to understand SCJ. If you do not understand an SCJ, then you cannot go ahead doing a colposcopy. So that's the main thing. So what is the significance of an SCJ? SCJ is that portion. We have two, right? We have a distant SCJ and the original and the new SCJ. Now, that is a squamo-columnar junction. Now, I'll come to those new and old and understand the basically of transformation zone. Why do we have to understand this? The first question to be asked is, the people who have attended my webinars would have always seen, I always go to why, because unless and until you really touch the base, you will not be able to understand the significance of these terminologies. Now, any lesion which has to arise, the HPV, the cause for a cervical cancer is human papilloma virus. Now, human papilloma virus is an epitheliotropic virus which requires dividing cells for it to be alive. For it to be as a highly dividing, cells, so from 5 copy numbers, it might go HPV to say 1,000 copy numbers. Now, how does that occur? It occurs because of the dividing cells. And where do you get these dividing cells? You get the dividing cells in the SCJ, because that's the dynamic epithelium. All right, so now first let's understand what is original SCJ. Now it is out over here, you can see columnar epithelium, squamous epithelium. So this is the prepubertal. With the advent of puberty, what is happening is there is a growth of the columnar epithelium, buckling up of the columnar epithelium. Where will it grow? It can't grow in that endocervical area, which is so small. It cannot go up because that's endometrium. It has to go into the least resistance area. Now that is your external os, least resistance area. And you will find that the columnar epithelium has very nicely traveled till wherever. So how do you understand that delineation? You understand by distal crypt openings. And we actually see, whenever I have conducted my programs, we have made our candidates understand first the original SCJ, then the new SCJ. So once understanding the original SCJ, we understand that this columnar epithelium is a single layered epithelium. It is bathing in the acidic pH. Now it has to get converted into multiple. So that conversion from a single layered fragile epithelium to a multi-layered robust epithelium is metaplasia. And now that is the dynamic procedure. Now over here you will see whenever there is a conversion of this metaplasia, and what is the cause for a metaplasia? Subcolumnar reserve cells. They are the totipotent cells, and they get the stimulation from the acidic pH, vaginal acidic pH. So that's the stimulant. So you see that these layers have become multi-layered, right? So now we have original SCJ and a new SCJ. Now the new SCJ is a combination or a junction between the columnar epithelium and the metaplastic squamous epithelium. It is called metaplastic squamous. So if we, first of all, it is immature and then mature. Immature means it is in the process of transforming. You still haven't come to the last superficial layer, now which has got the glycogen into it. So they are immature. And then mature is when there is a stratification. What do you mean by stratification? That is having a glycogen in the cytoplasm of the upper layer, superficial layer. So they are stratified squamous epithelium. So out over here, we have a junction. Now this is the new SCJ. How do you identify this new SCJ? Only after putting 5% or 3% acetic acid. Then you will have the white line being delineated very nicely, step-like manner. And then you have the original SCJ, new SCJ, and the transformation zone. When this is seen, everything seen clearly on the cervix. Like you can see the red columnar epithelium, then you can see the metaplastic. How do you understand a metaplasia? I'll come to that. Because the colposcopist eye should be able to identify a metaplasia from a lesion, because that is also looking white and this is also looking white. How do I delineate distinct the whiteness? So that's where the beauty and art of colposcopy is. And then this is TZ1. What is TZ2? I said that this is a dynamic procedure. So you can see over here, this whole things are also be turning into metaplasia. And so now your SCJ is on the os. Still you can see a little patch of columnar epithelium, squamous epithelium, that's TZ2. What is TZ3? Now the remaining columnar epithelium is also getting converted into metaplasia and squamous metaplasia. And so now the SCJ has shifted inside into the endocervical canal, that is TZ3. So I understand, dear friends, we all have understood TZ1, 2, and 3 in a perfect manner. And the lesion usually arises from SCJ. I was telling you that the dynamicity of this epithelium that attracts the HPV. I mean, the HPV gets attracted towards the dividing cells, and hence you should be able to understand SCJ, whereby you will understand this thing, lesion. So this is TZ1, as I told you. You can identify the distal crypt opening by the pits. All right, so I'm not going too deep into it. And then this is the new SCJ. This is the transformation zone, TZ1. Now we have this as a TZ1 again. What is an ectropion? Only when this whole of the columnar epithelium, it occupies 2/3 of the squamous epithelium. That's ectropion or ectopy. Now over here is your TZ2. The upper layer is still the thing is on the os. Down you can see a little bit of columnar epithelium. Now this is in the premenopausal or perimenopausal or menopausal age group. You can see plenty of blood vessels also. Why so? Because the epithelium has become atrophic. And then this is TZ3. You can see petechial hemorrhages also because of the atrophy of the epithelium. Now that was your stromal papillae I just told you, and then in between is the retipeg. This is the area where actually the dividing cells are. Or normal dividing cells also, you will have a normal retipeg. That's not a problem. In a case of a menopausal age group, you will be able to understand fine mosaics and fine punctations. They are actually not any pathological significance. only when there is a widened retipeg because of the dividing cells, retipeg widens, and then that is where you can, from the head-on view, if you can see my fingers on the thing, these are the head-on view. Now it has increased because of the dividing cells within this. If you think this at the stromal papillae, and these are the dividing areas, if you see from head-on view, you can see a mosaic pattern. Now that's where exactly the coarse mosaics and the coarse punctation does have a significance. That's what I brought it over here for you all. Now we have a colposcope. I was very lucky to be in those days with Usha Saraiya madam in our alma mater Kama, where we used to have, madam still has that binocular colposcope, and that's where she used to make us sit and see, ye dekho mosaic, ye dekho, and all that stuff. So we used to enjoy. Our date actually started from those days. And then now we have this video colposcope. Colposcopy character biopsy is the gold standard. People have been asking me, like I would have trained more than 1,000 gynecologists so far and so forth in the art of colposcopy. People have asked me one significant question, which I would like to address over here too. What is the use of a colposcope? When I can see on a VIA, I can see the screen. I take a punch biopsy and that's it. Why should I require a colposcope in the first place? So the answer to this is, in a VIA, okay, let's understand. Like I've been teaching VIA now very rigorously in my SSNPP webinars. VIA makes you understand the, SCJ dig jayega, but you do not really understand the TZ zone in a better manner. Second thing, what you don't understand, green filter is not good, so abnormal blood vessel patterns cannot be delineated. A colposcopy is a stepwise procedure. Only if you have those stepwise procedures, you can come to a scoring system. The purpose of scoring system is what? If you want to take up a patient, say in a high grade lesion, aapko samajh nahi raha hai ki should I refer, should I do an excisional biopsy, should I do LETS or a cone biopsy? Or in a low grade lesion, what do I do? So the answer to this goes is only when you do a stepwise colposcopy, come up with the sweet scoring and then talk about it, the treatment and management part of it. So the steps of colposcopy, yes, I do understand that we all know. We will take a consent. We will explain the colposcopy procedure. देखो दूरबीन देखकर ही लोग डर जाते हैं. Ladies literally run away. When you tell colposcopy, they do Google, cervical cancer, ho gaya, and they start crying to the tune of, they just spoil themselves. We as a colposcopist have to give them a beautiful counseling. So the counseling is the important part before taking up for a colposcopy. And then after that, when we do a counseling, we have taken a consent. So first step is cleaning with a normal saline. What do you see on cleaning with a normal saline? Look for the distal crypt opening. You identify the SCJ. Do not jump into new SCJ. Do not go for a TZ to be said immediately with a normal saline. No. Just wait, identify distal crypt opening, then understand any polyps, Nabothian or hyperkeratic patches. Then slowly go into green filter, identify the blood vessel pattern. I tell you, you will fall into love with colposcopy. That's the reason I have coined out date with colposcopy. Why? Because of this blood vessel pattern. If you can understand the normal blood vessel pattern, abnormal blood vessel pattern, it gives you, I'll be coming to that as well. I'll come to that. And then goes is with you switch off the green filter. What people have done mistakes, people haven't come back to the white base and they have applied acetic acid and everything was green and the interpretation went haywire. So you will have to tell to yourself, have I switched off? Come to the white base. Then apply an acetic acid to find out 1 minute of application, 1 minute of understanding the lesion appearance, and then goes to Lugol's. Okay. So now we come over here, normal saline is applied and we are seeing the distal crypt opening. So understanding the distal crypt opening gives us an understanding of distal SCJ. So iske pare kya hai? This, the portion beyond it is your original squamous, and the distal and the area which is within it, inside it or proximal to it is the metaplasia. So that is the understanding. So beyond this, you're not going to comment anything because it's a normal thing. You're not seeing anything else in it. Come to green filter. These are the routine green filters. Ab ye dekhiye, this is the reticular blood vessel pattern. I am not exaggerating, dear friends. I'm in no mood of exaggerating, but dear me, if you really see a colposcopy and try to understand blood vessels, Whatever I'm saying, inch by inch word is truth. This you will see it in a reticular, you will see it in the original squamous epithelium. These are staghorn patterns where you'll see it in the trichomonial. Leave this. This is also important, regular blood vessel pattern. You will see this in a metaplastic epithelium. This you will see it on the nebotheal. I have treated many cases which were told to be tumor only because of the blood vessel pattern. This blood vessel pattern made me understand Nebothean, infected Nebothean cyst and all that stuff. Okay, then these are hairpin bend pattern. You will see plenty in a atrophic epithelium in a menopausal age group. Long parallel blood vessel pattern. You will be very nicely seeing it in those areas where you would have treated that. You know, a post-treatment, she comes for follow-up, relook colposcopy. You would see that long parallel blood vessel pattern which was there before. I mean, wherever there was a lesion, it is healing. So this is for healing tissue. So here I have brought for you Nebothean, and this is the parallel blood vessel pattern. You can see here what I told you as reticular blood vessels pattern. It is seen very nicely over here. And then you can see the branching patterns, and these are into Nebothean. Again, same over here. You can see plenty of blood vessels out over here. It is more evident what I'm trying to say. Now come to abnormal blood vessel pattern. Now the hairpin bend pattern would have widened up, corkscrew type, then tendril type, comma type, waist thread type. These are, if you see this abnormal blood vessel pattern during putting the green filter, what you would realize is this area might be a problematic area. You will keep that in your mind. Then when you apply an acetic acid, you will try to find out a concordance of aceto-white area on that abnormal blood vessel pattern area. Now see over here, you can see a little bit of mosaic patterns as well. And out over here also it's very clear. And look at these patterns. This is normal, this is abnormal. Look at this area, you have this tendril type of pattern, comma type of pattern. These are certainly showing us preclinical CA. Acetic acid application. Acetic acid coagulates the intracellular protein, thus obscuring the passage of light, turning aceto-white. 5% acetic acid. How do you make it? There has been certain incidences which I truly quote in all my lectures because that's an eye-opener for all of us. One of my candidate who had learned from my colposcopy workshop went back, and the next day he gives me a call saying that Priya, uska to vagina jal gaya. I said, what did you do? He said, "Maine jaise tumne kaha 0.5 and 9.5." I said, "You have changed the mixture," because he said this to his staff nurse. Staff nurse took it otherwise. So these are very practical things. Whenever you are instructing, tell 0.5 ml of glacial acetic acid, 9.5 ml of distilled water. Ye pure aapko batana hoga like a slogan. Otherwise, people can. So that's a 10 ml. 20 ml is 1 and 19, and 100 ml is 5 and 95. Now we do have, whenever you are putting up acetic acid, what will you first see? You will see for the SCJ, newer SCJ. Sometimes a metaplasia. Now this is where our beauty, our eyes are. Our eyes have to be tuned to understand a metaplasia from a lesion. How do you understand that? A metaplasia aceto-whiteness, because that is also a high NC ratio because of the dividing cells. They are thin, they are shiny, they are translucent. They are finger-like, feather-like pattern. It can arise anywhere. It arises early, disappears fast. So they are translucent without any geographical pattern. So what do you see? You will see for newer SCJ, metaplasia. Now columnar epithelium sometimes also turns white because of metaplasia. People have misinterpreted that. People have, even in the national forum, whenever we had a panel discussion, said, you have to put a lesion here. So don't be in a hurry to give your interpretation. 1 minute of this thing and 1 minute of observation. That 1 minute of observation is the magical tone. The squamous metaplasia arises and disappears. Ojhal ho jayega. Aankhon ke samne it becomes red in color. Whereas a lesion will remain. So columnar epithelium covered with squamous metaplasia, they are not lesions. Do not even think about it, they are metaplasias. Then satellite lesion, congenital TZ and hyperkeratic patch. I brought a metaplasia for you to make you understand how do you identify a metaplasia vis-a-vis to a lesion. You can see over here, thin, shiny, translucent. What do you mean by translucent? I am able to see the underneath tissue. That's translucent without any set geographical pattern, merging with rest of the tissue. That's metaplasia. It arises and disappears fast. Whereas a pathological VIA will have different patterns. You have a pattern coming up from SCJ. You have a raised pattern. You have a circumoroficial pattern. I'm getting to you those pictures now. In many pictures you're going to see. You will have a tweet as a date. The name is date. You will have a tweet with the pictures now. Now then, what is VILI? VILI is a visual inspection with Lugol's iodine. The principle behind is a stratified squamous epithelium has glycogen which turns mahogany brown. The cells which do not have glycogen will not turn brown. So which are the areas which will not turn brown? There are two things. Whenever we talk about it, we say villi positive, villi negative, or not taken up. So if it is not taken up in a pathological manner, you call it villi positive, right? So which are the cases which will not take up? Like original squamous epithelium will take up. Mature squamous metaplasia will take up. Physiological conditions where Lugol's will not be taken up, columnar epithelium will not take up. Immature squamous metaplasia will not take up. It will not turn yellow, but it will not take up mahogany brown. There are two different things. Turning canary yellow is a lesion, and not turning yellow, but not taking up the Lugol's. That's where you say as Lugol's not taken up, and they are the physiological conditions. Now, menopausal epithelium. Now, what I tell to all my candidates who have taken the training under me, that please do multiple time of colposcopies in a reproductive age group before you jump to menopause, because menopause में सब कुछ white दिख रहा है, सब कुछ पीला दिख रहा है. I'm not able to understand a lesion, and where do I take a multiple biopsy? And that's a fragile area. So वो भी, it keeps on bleeding. So be cautious, friends. Only 50 cases of reproductive colposcopy, then going out for doing a menopausal. So this is your thing. Now, why is this not taken up? Because this is a crypt opening, which is being collared by immature squamous, immature columnar metaplasia, immature metaplasia. So not taken up. All right. Now, villi positive cases, as I told you, lesions. Now, why is lesion not going up till that level? Because it is highly dividing. It doesn't have time to go into those divisions like basal, parabasal, intermediate, and superficial. Most of the dividing cells, if you see on a cytology, because I'm also a teacher for cytology, and I have been training my candidates under microscope, you would see the HSIL cases or high-grade lesion cases are having only basal and parabasal, characteristics of the cells. They are never gone into those intermediate basket weave pattern or the superficial. They have never. So basal, parabasal structure. So you have, and they cannot take up because of no stratification. Now, trichomoniosis gives you a picture of, a leopard skin patch. What is that leopard skin patches? They have denuded those areas, trichomoniosis, chronic cervicitis. Because of those denudations, those areas, when you apply a Lugol's, will be raw. The stratified layer has gone away, and hence you will see in patches. So they are. Now over here, I have brought this picture contains a leopard skin patch. This picture also contains a lesion arising from SCJ, a lesion arising from SCJ. Will you say this as a lesion? These are satellite lesion, not arising from SCJ. You won't call it as a lesion. आप बोल सकते हो satellite lesion, but please do not go in running to do a biopsy. No need. Whenever you do a biopsy, you have to take it from SCJ. Then you have multiple. So this was your SYN 3 and this was your SYN 2 in an individual biopsy. But you do not have to worry about that, because a high-grade lesion, unki treatment is the same. I mean, that we'll come to that now. So immediately I show you colposcopic this thing. I'm going very fast a little bit of the first of time. Here we have applied the acetic acid. So before that, okay, I think I should go step by step. Now over here we are cleaning it with normal saline. We have cleaned it. Now in the normal saline picture, just freeze it for quickly. You will have to see the distant SCJ. All right, that is what I'm seeing. Otherwise, I'm not seeing anything. So I'm not putting up anything now. After this, go for green filter. What do you see in a green filter? So is the normal saline also, now we are applying, once we are applied, it removes the mucus. That's very, very important, because having the mucus will not be able to actually see the lesions underneath it. So once cleaned it, going with a green filter again, normal saline ka ho gaya, interpretation. And dear friends, see to it that the cervix has to be in the center, please. If the cervix teda meda hoga, so that's what I've written in my books. How do you centralize the cervix? Because sometimes cervix is here, cervix is there. Do not touch the cervix. Touch the counterpart of the fornix. Give the pressure there so that the cervix turns to the center. That's how the thing is. Unless and until the cervix is completely seen, please do not start the colposcopy. People have done adha adhura kaam and then the lesion has left out. In the green filter, try to understand the blood vessel pattern. Then you have come back to the white base, and then you start putting, I'm like now I'm going quickly fast into it. Okay, I've started now interpretation. I want to show you all interpretation. Now, after applying acetic acid, where is the SCJ? Now that is where the people get little disturbed. Now let's see where is the SCJ. Let's delineate it. Now see, here also I'm seeing white. I'm seeing columnar epithelium here also. Where do I put my SCJ as? So that's the main question. So these are all metaplasias on the columnar epithelium. So you would see over here, but these are granular, these are velvety. So I understand this is, if I have to now just observe my this thing. I am showing SCJ. My cursor is showing SCJ. That's it. And what are these? At 1 minute 9 seconds also, I have started getting a lesion pattern arising from SCJ. A dark, dense aceto-white area going endocervix. Traveling into the, and all these are white patches. So now let's understand. Now you have to be observant in this 1 minute. How do you understand a lesion? How do you understand a metaplasia? That's it. Now this is, the clock is ticking and we are now observing this pattern. Now kindly observe keenly. All the aceto-white areas are just disappearing in front of your eyes. You will see that. And only the lesion pattern remains. And that is where our observation should be. You can see the difference between this starchy aceto-whiteness and these feathery aceto-whiteness. You can see this. These are all metaplasias. You can see over here as well, this starchy aceto-whiteness has remained. What is the time? 2 minutes 3 seconds, 2 minutes 4 seconds. You can see a dense aceto-white geographical pattern arising from SCJ. And whereas all the other things have disappeared. So we have understood that we have 3 lesions to tackle. One is this, one is this, and one is the above one as well, which is going little endocervix. Beyond this, what we do is we apply Lugols. That's applied. Lugols doesn't have to be diluted. Just take it up and put it. Now again, when I have applied Lugols, everything is looking yellow for me. How do I understand what is lesion now? Because these are the practical tips where people are fumbling and not able to interpret. So you will see over here, look at the color difference. This is really canary yellow and these are not taken up. There's a little different color. If I'm making sense of what I'm saying, you can understand. And now let's sit back and try to just analyze the epithelium. You will see in few minutes, these not taken up one, which was just painted because of metaplasia, just columnar epithelium doesn't take, it just get painted. They all will disappear. In front of your eyes, they all will turn into pink. Just to observe for some time. So here itself, it has started. See, it just started turning. Wherever there was this yellow business, that yellow metaplasia, you can see it has washed away, nicely washed away. Everything has started turning pink, whereas this has remained yellow. Other things have become pink. And you can see over here, so we have 3 areas to get as a biopsy. Now, people have, I was very surprised when people say to me that we do biopsy under local anesthesia. No need. Just nice, good. Where will you take a biopsy from? Again, that is an area of this thing. So we have taken a Tischler's. You have to take up SCJ. No matter what, even like if this area looked for me very terribly white or terribly yellow, I go to the periphery and take a biopsy. No, your biopsy should include squamo-columnar junction for it to be. So now where I've taken, we have taken the whole punch and you should have a sharp tooth, toothed, Michler's biopsy forceps or Tischler biopsy forceps. When you have taken this, apply a nice cotton or, those creams we can put. Otherwise, it doesn't bleed. This is to the 11th time of magnification. Hence, this is looking like bloody. But it is not. It's just minuscule. You don't have to worry. Just put a pressure bandage. Then that is also a pressure. That's also enough. So we have taken from there also. And then clean it. Put a tampon inside. You can leave her, give her methampsylate if you want. So that's your procedure. After the procedure, you have to put it into the Cartier diagram. Very important.
Dr. Priya, sorry to interrupt.
I have come to my end of just scoring. So you have this IFCPC nomenclatures. So quickly, I will just take 1 minute if you permit, because this is very important.
Sure.
Yeah. So you have this as an adequate colposcopy, inadequate colposcopy. People still are talking about SCJ, visible, not visible, as satisfactory, unsatisfactory. So the terms have changed. Adequate means you can see the cervix without any bleeding or scarring. These are your TZ, SCJ seen partially, completely, not visible and all that. Then you have mature metaplasia. This is islands of columnar epithelium. Now this is metaplasia. This is atrophic. These are Nabothian. Now this is your ectopy. And these are not chale and all that thing. So we have to come out of those terms. Then lesions, minor grade lesions, major lesions, which you are seeing, minor, major, and these are your invasions and ulcerations, necrosis. Other findings, miscellaneous findings, these are congenital TZ. I was very lucky in my lifetime. I would have done more than 75,000 colposcopies till date. I found 2 congenital TZ. You can see over here. Then these are the polyps and condyloma. Then these are your, congenital anomalies like walls, septums, double cervix and all that. So in a colposcopy, it makes you really understand. Then this is what endometriosis, fibroids, multiple infected Nabothian. Then these are herpes infections. So going to that is what we do is sweeting. We all know the sweet thing. I'm going quickly. So we have this as a low grade lesion, which we have sweeted it to a 4. Then we have this high grade lesions coming up. The sweeting pattern is fixed, acetowhiteness, lesion delineations. Then, you see for blood vessel patterns, you see for size and site, and then you see for Lugol's. So you have to see the concordance with histopath, and that's exactly what we do when we come. Now, when we have all these things, this is sweeted 10, you can see over here. Now, these are carcinoma in situ. Then you have this mobile ODT these days, which are also giving you understanding of how do you compare it. Beyond this, also mobile ODT has AI interpretations also. So with your concordance with the experts can be done. But when we talk about VIA and we talk about screen and treat, it is a public program. See and treat is a colposcopy clinic program. Now we have wonderful thermoablations also available over here, where you can see that I'm just doing. Now this is from the company Viseps is what I've been using. It has got a shield. You just have to touch it 40 seconds. It beeps. And that's the desiccation of the intracellular water. Once the intracellular water gets desiccated, you can, the cells get denatured, and that's how the treatment occurs. So these are, nowadays we get wonderful thermoablations with a timer, with beeps and all that, and it gives you multiple application, this thing also. You can once here and then once here, you can do that. So this is what I've been using, and then is a case management. So now I will not go ahead because of the lack of time. I had brought few videos on Cryo and LEAP also. So we do not have a dead end. It's definitely an alternative ending. And we do have these books and lot of training programs is what we do. And then we have this instruments has to be there. So of course, as Usha madam said, everyone's dream is cervical cancer Mukt Bharat. The dream will turn into a reality one day. Thank you very much for giving me an opportunity. And I'm honored to be with UPCOG. Thank you, Dr. Kiran.
Thank you, Dr. Priya. Wonderful lecture. And really, actually, I didn't want at all to stop you. You were explaining wonderfully, so basics, clear, making it clear. But we do have to respect the time and the things have to be done. I wish we could have actually managed it in a different way. Maybe your lecture was only sufficient. So, but
Dr. Neela Mishra is there, and Dr. Kiran, I am not seeing her in participants. So just to give a short, I'm not seeing her. Dr. Neelam, are you there? So you give your concluding remark, or I will conclude the session then. I'm not seeing her.
I think then Dr. Sadhana, you give the concluding remark.
So thank you, Dr. Priya. Once again, it was a real treat and a date. And what we say, what you emphasize with all your things, what is the actually enigma of today's medicine, that first understand normal. Because what is the concern that the people come with the simple images and everybody says, like patient says, oh, it is abnormal and it may turn into cancer and it is better to get with the hysterectomy. So understand normal, and that is the most complex thing. And what is the beauty of colposcopy is that you are visualizing the thing. It is direct experience. So no HPV reporting and all related confusion. And it is not, it is you who are visualizing. It is you who are taking the decision, and it is you who are like guiding the patient for further plan of treatment. So once again, hearty congratulations, Dr. Priya, and hearty congratulations to Dr. Kiran Pandey and all the team of UPCOG for this program. And Priya, you keep on doing this work, because we really want a good observation and a good experience of colposcopies in our all federation. So once again, best wishes, and thank you very much, Dr. Kiran, for this opportunity. Thank you.
I think Dr. Priya, your lecture, everybody wanted it in more detail. So can you put your slides or something into like some, for the audience benefit, you can put your slides into the, we are very, sorry to interrupt in between.
Yeah.
Okay, so proceed.
Thank you so much, ma'am. And we have seen we have rather witnessed your love for colposcopy, and after your lecture, we have all fallen into love with colposcopy. So, and thank you so much, Sadhana ma'am, for concluding so beautifully. And as there is paucity of time, so the time allotted for audience interaction won't be possible. So if there are any questions that can be taken by Priya ma'am in chat box only. So now it's time to invite my colleague, passionate, punctual, and very pretty, Dr. Pavika Lal ma'am, Assistant Professor, GSM Medical College. Ma'am, please proceed.
Thank you so much, dear Pratima. Mera sabhi ko bahut bahut namaskar. Thank you so much, Priya ma'am, once again for a wonderful video on colposcopy with important key messages. Now, without wasting any time, I would like to call a respectable Kiran Pandey ma'am, along with our very honorable Urmila Singh ma'am, for a wonderful and interesting panel discussion on pre-invasive cervical lesions. And at the same time, I want to call upon my stalwart panelists, very esteemed and distinguished, Amrita Chaurasia ma'am, Sapna Singh ma'am, then Kiran Sinha ma'am, Parul Sinha ma'am, Priyanka Garg ma'am, and Pragati Agarwal ma'am. Sorry, as everybody knows, everyone, I have not introduced anybody just because of the paucity of time. But then again, we are more focused on academic session. So, overing you, Kiran ma'am, for the panel.
Okay, thank you, Pavika. So, please allow me to share my presentation, and let's go back. Is it visible?
Yes, visible. Yes, yes.
Okay, let me make it full screen. Okay, so welcome Dr. Urmila, senior consultant, and my very dear friend as a co-chairperson, and we'll start with the welcome all the panelists. So we will straight away go to our case presentations so that we are able to save the time. Sorry. Yes. So Mrs. Jet, 38 years old female, P1+0, came to gynae OPD for regular gynecological checkup. The patient has, as these days happen, they are Google friendly. So she has read about cervical cancer and is well aware of it. She is carrying her PAP report also with her. The report is, we'll tell you, but before that, for the audience purpose, I would request my first question. Yes, Dr. Amrita.
Yes,
What are the prerequisites of pap smear? Amrita, please explain, because many a times when the report doesn't come correctly, then we are in a dilemma. So,
yes, ma'am.
what are the
A
exact
very good evening to all of you, all respected seniors and dear colleagues. So, ma'am, prerequisites are very important before taking pap smear, because the prerequisite basically, if you are not following it properly, it may affect the false negativity, and it may make the poor yield of the smear. So the basic number one is the patient should not have within 72 hours, she must not have anything inside her vagina like sexual intercourse or any spermicidal jelly or even vaginal tablets, or sometimes douches some of the women are using. Preferably 72 hours, but 48 hours to hona hi chahiye uska abstinence. And second, ma'am, she must not be having any infection, because the inflammatory cells, the infection, they mask the abnormal cervical cells. She must not be in the bleeding phase, menstruation ke samay nahi hona chahiye. And third, the patient, while taking pap smear, we should not use any antiseptic solution or any douching of the vagina. Otherwise, this may again wash off the abnormal cells and may yield a poor smear. So these are the prerequisites we must follow.
Very rightly, Amrita, you have described all the things. The only thing which also is important is, in those cases, if the already bleeding is and we are suspecting intraepithelial lesions, then we can proceed, because sometimes they are part of the disease itself. So there we cannot delay. So there
Yes,
we can
ma'am.
take it. Otherwise, menstrual bleeding, of course, we should not.
Next, I was going to say that only in our practice scenario, the patient may not return you back. So even if you are suspecting it, it is better to have the smear and then call her after some time to take another smear, a good quality smear.
Very
so that
correct.
will be the message. Yes.
Okay, so Dr. Sapna, again for the purpose of simplifying and correctly taking, how do you take smear? Will you be able to elaborate it a little bit more in detail? Dr. Sapna?
Yes, ma'am. Yes, ma'am. Am I audible, ma'am?
Yes, yes, you are audible. Audible, please.
Good evening to all of the respected seniors. And coming to my question, then how to take the pap smear. First of all, cervix is exposed with a cuscosis papillum, and we should not use any lubricant, or no pervaginal examination should be done prior to taking the sample. And material from the cervix is to be collected by Ara's spatula, and whole of the scapulocolumnar junction should be scraped by rotating it by the 360-degree angle. And the second sample is to be taken from the exfoliated cells from the posterior fornix. The sample can be collected by the glass pipette or by the Ara's spatula.
There is disturbance from somebody. Please, the rest of the panelists, please keep yourself unmuted so that there is no disturbance.
किरण सेंट्रली बंद करा दो, सेंट्रली बंद करा दो।
मैम जो पैनलिस्ट हैं उनको अपना ध्यान
नहीं, पैनलिस्ट को कर दे, ये कोई और का आ रही है शायद।
हाँ, हो सकता है मैम। टेक्निकल टीम प्लीज लुक इनटू दिस।
मैम एक्चुअली ये साउंड लास्ट जो कल पे प्रैक्टिस में सपना मैडम की तरफ से आती है थोड़ी मैम।
अच्छा, सपना प्लीज ध्यान रखो।
हाँ,
ओके ओके, गो अहेड फॉर Sapna, please continue. Anyway, so basically the main important thing which Dr. Sapna has told very rightly, that the two samples,
and the third sample is to be taken from, and we have to take the three samples. One is from the, and in third sample we spread the sample on the glass slide, and before it get dry, fix with the 95% alcohol, and after fixing for about 30 minutes, slide they are to be air dried and sent to the lab for the
सपना, तुम्हारे यहाँ से कुछ साउंड में प्रॉब्लम है.
Okay, Sapna, so we move ahead because that was just important thing to understand. What I wanted to say, normally when we take a spatula, we have to rotate it 360 degree. That is from the ectocervix. Do not use much force and do not use less force because that otherwise it will be inadequate sample. Endocervical sample is very important, and for that 180 degree rotation is enough, and the sample is taken off. So this is just to show you how do you take a, so many times what happens, the endocervical sampling is missed. So that's what we wanted to emphasize it. So let's come to the next question. The Dr. Kiran Sinha, if, yes, this patient has come with a pap smear showing positive result, the ASCUS, atypical squamous cells of undetermined significance. So now if the HPV is positive, the ASCUS is positive, what to do?
Yes, madam. ASCUS means atypical cells of squamous of undetermined significance. It may be due to many causes. At HPV infection, it may be due to inflammation, as an infection, yeast infection. It may be due to some benign lesion as yeast or anything. And if it is HPV positive also, then you should see the variant of HPV. If it is 16 and 18, then you don't have to wait and go another for HPV. For this pap smear test, you directly go for colposcopy because the 16 and 18, they are very positive organism to develop the carcinoma cervix. So we don't wait for them. But if it is HPV infection is not this 16 and 18, then you can go with this pap smear testing again. And if it is again positive, then you can go for colposcopy. And if the pap smear report comes as negative for intraepithelial lesion, then yearly co-testing is advised. That is with HPV and the pap smear test. That is all, in short.
Yes, so basically the ASCCP guideline, if it is positive, you can do colposcopy, and if needed biopsy, normal, then co-testing, otherwise management as CIN. So let's come to the next case. If this the HPV is positive, decision for biopsy has been taken and the report has come CIN positive. So now what to do, Dr. Amrita?
Yes, ma'am. Since she is HPV positive and her biopsy is showing SIN1. SIN1 has got very high reversal rate. Many times in 60 to 80% it reverses back by the end of second year. So there are two thoughts. If the patient is compliant, you can have her in follow-up by the repeat test. Otherwise, it is always better because in our OPDs, they are many times they are not very compliant. So it is always better to do some ablative procedure in the form of cryosurgery and keep her under follow-up. And since she is SIN1 positive, so we will keep her under follow for another next 25 years. So that is the what recommendation is saying nowadays.
Absolutely correct, Amrita. You have told a very practical approach of screen and treat, that you do a cryo in the same sitting. Although ASCCP says that you can do 1 year follow-up, and because as you rightly said, CIN1 many cases regress. So we can take up the strategy of observation and keeping the patient into surveillance, and if not control after 2 years also, then consider ablative or excisional. But it all depends on the patient compliant or not, then on that basis only it will go. So the next is Dr. Sapna, what will you do? What are the Dr. Sapna, what are the eligibility criteria for ablative procedures?
The eligibility criteria for the ablative procedure is that the whole of the lesion should be visualized in the transformation zone, that is, it should not occupy more than 2 quadrants of cervix. And second is, there should be no microinvasion or
Sapna, your net is not at all, net is very poor, so we are not.
And no disparity between the cytology followed by the largest
Voice is not clear.
and the last endocervical gland and
Okay, so
hello?
the basic
Hello,
thing.
I'm audible. Hello.
Hello.
Ma'am, am I audible?
Sapna, you were audible, but because of internet problem, we could not exactly. It was not correct, but very rightly you said the lesion has to be entirely visible and occupy not more than 2/3 of the cervix, and this should be located on the actocervix without any vaginal or endocervical lesion, no suspicion of invasive cancers, and it has to. This lesion should be covered, that the largest probe can at least cover it. That is the important thing. So basically, WHO now prefers excisional procedures over ablative procedures. That is the message which we wanted to give it. Now, if both ASCUS and HPV tests are negative, Dr. Parul, what would you like to do now? Dr. Parul Sinha.
Yes, ma'am. Ma'am, if both ASCUS and HPV tests are negative, then we have to rescreen the patient after 5 years, because co-testing has to be repeated after 5 years. And so I don't think there's much to say.
It's all right. It's a very clearly crisp answer you have given, that in these cases, 5 year, you have to do the co-testing otherwise. So, Dr. Priyanka, what if supposing, although Amrita has covered it, that if it is the ASCUS with unavailability of HPV testing?
Yeah, good evening, ma'am. See, ASCUS is the group which is very difficult to treat, basically. But we don't understand what to do, what not to do. So it is always better if the report is ASCUS to do HPV testing. But if ASCUS patient is not basically affording HPV test, or it is not available, then a course of antibiotic has to be given, because it can be infection, and you need to repeat the cytology after maybe 6 months to 1 year, ma'am. But we should be very a bit earlier in repeating the cytology, so that we can pick up the progression or regression of the changes and see what significance ASCUS had.
So rightly, Dr. Priyanka, if HPV would have been there, then we would have done the code testing, otherwise 3 yearly. But here we will do 1 yearly, so that we don't miss anything. Now, Dr. Pragati, will you be able to tell if there is a ASCUS with HPV test not available and patient is not compliant?
If patient is not compliant, then we will not leave the patient like this. We will perform colposcopy or visual inspection with the acetic acid. And if there is any suspicion, then we will take the biopsy.
Yeah, Dr. Priya has very nicely already showed so many of the beautiful lesions from bare basics, how to take it. After VIA, you can take the biopsy. And this transformation zone also, just for the knowledge already, Dr. Priya has told, the transformation zone 1, 2, and 3, which are seen in this diagram, that type 1, where it is totally on the ectocervix, in a type 2, which has gone into the canal, but is still fully visible, and in the type 3, where it has gone more into the endocervical canal. The size of the lesion, large or small, does not matter, but decision depends on that it is totally visible or not. Now, so Dr. Kiran Sinha, will you be able to tell us a little bit what is the LEAP, or the loop electrocautery excisional procedure in short?
Yes. Loop is loop electrosurgical excision procedure. It is basically a excision procedure, and it is diagnostic and curative both. It is diagnostic and curative process. In this, a loop is inserted into the cervix, and under the colposcope, then we examine the areas which are abnormal, and then we connect it to the electric current and we excise that abnormal areas also. And in this way we do the treatment also, see and treat. And in this, and the tissue which is obtained, then we send it for the biopsy also. And after this leap also, again after 6 months you have to go for the pap smear and testing. In short, ma'am.
Yes, yes, Dr. Kiran, you have said well, loop, you can see the loop itself, and with the help of this fine electrical loop, you can take out the diseased area. And this slide, I think this is a very good slide. So I wanted to show you, you can see that this is you can see that diseased area is being taken almost 2 millimeter beyond the diseased area. You can take from the loop. So if there are two, you can take two, the loop excisions can be done, resection can be done. So, Dr. Parul, will you be able to explain us a little more in what is the difference, how to differentiate leap, LEDs, and nets?
Actually, LEDs and leap, they are the same thing. They are different terms for the same thing. Loop is LEDs is loop electrosurgical excision of transformation zone. Leap is also excision of large loop excision of transformation zone. And nets is needle excision of transformation zone. So leap and LEDs, they are same thing. So LEDs is basically used for, it can be used for removal of type 1, type 2, type 3, all, but nets is used for type 2 and type 3. So various studies have been conducting, comparing this needle excision of transformation zone. And so it has been, few people, they said that it is better to use nets when the endocervical tissue is involved. But the studies which have shown, they have shown that almost equally effective. But some people have said that the incomplete resection is less with nets. The positive margins are found less with nets. So there are higher probability of, but nets has a higher blood loss compared to LEDs, and the surgical procedure also takes a longer time.
Nicely explained, Parul. The only thing which I would like to little bit clarify more, I think this diagram explains it very nicely. This is leap when you are only excising the affected part. This is you take 2 millimeter beyond it, whereas in LEDs you take the whole squamocolumnar junction, and this is a wider cone you take, and of course endocervical area that you have selected. So just a minor difference between the leads and the LEDs, otherwise procedurally they are same. So that is the thing, and nets you have already told the studies. We'll move ahead. Now, second case, I will hand over the mic to Dr. Urmila for a quick second case. Dr. Urmila?
Yes. Namaste to all our respected faculty, and thank you, Kiranji, for giving this opportunity. The second case is a 30 years old para 1+0 presents after routine co-testing showing negative pap test and positive HPV testing. She was previously screened with the cytology only one, but has not been screened since last 5 years. She had multisexual partner in the last 1 year. Next slide. So the question to the Dr. Priyanka Garg, what is the next step? Priyanka? Dr. Priyanka?
Ma'am, there was a problem with the internet here, ma'am. Can you please just repeat the salient part of the question?
Okay.
She came with a pap test negative and
positive
HPV positive.
Yes, ma'am. Ma'am, HPV, if it is HPV positive, it is always better to genotype the HPV stain, because we know certain stains are more like 16 and 18, they are more prone to cervical cancers. And secondly, you need to be pap negative, so you can repeat the co-testing after 1 year, and it is better always to do a HPV DNA genotype. And if it is a very, very high risk genotype, then even if the pap is negative, it is always better to proceed for a colposcopy and look for any abnormal areas.
Very well said, Priyanka. So you can only follow with the 1 year co-testing, HPV testing, or if the genotype is available, then you can do it. Now her co-testing in 1 year. Next slide.
Yes, Urmila, it is there.
Previous slide.
Okay.
Her co-testing in 1 year is PAP negative and HPV 16 positive. Next. Dr. Pragati.
Yes, ma'am.
What do you do now?
As she is HPV 16 positive, these are at high risk of CIN3 and occult cancer. Therefore, I will not leave the patient like this. I will do colposcopy, and if there is any suspected lesion, then biopsy should also be taken.
So the HPV 16 or 18 infective have the highest risk of CIN3 and cancer, and occult cancer are there. So additional evaluation is necessary even when the cytology is negative. So colposcopy was performed, biopsy taken. The report shows that CIN1. Then how will you manage this case, Dr. Amrita? This question to you, Dr. Amrita.
Yes, ma'am. Ma'am, CIN1 हम लोग management discuss कर चुके हैं. Here the most concern is why she is having persistent HPV infection, because she might be immunocompromised as well. So we will have to take care of that. We will have to check her HIV status as well. And since she is HPV 16 positive and CIN1, so we will proceed with some ablative procedure. As madam said that now the WHO recommends
excisional procedures.
Excision over ablation. So depending upon, upon, we will decide the management. We will not leave her. That is, ma'am.
Okay, very well said, Amrita. And one study was done that shows how much there is the risk of this CIN3 and pre-invasive carcinoma cervix, and that shows that there is the less risk of progression to the cancer. So the ISCCP 2019 recommends 1 year follow-up with the HPV based testing is recommended.
Yes, ma'am. That is what we have already discussed. CIN1 high reversal. By the end of 24 months, 80% regresses. So if the patient is compliant, we can put her. Otherwise, we will do a procedure, because many a times our patients cannot be relied upon. And she is HPV 16 positive as well.
Okay.
And for CIN1, we can go for ablative procedures as well. Excisional are better, but they're not available anymore. But for CIN1, no.
For the CIN1, it is said it is an observation is the better. It is recommended. It is recommended. Because the patient, usually young patients.
Foreign countries, they recommend because their patients are very reliable. They come back. But in our country,
very rightly. It depends on the compliance of the patient, but the desire of the pregnancy. Yes, all this will be taken in the consent.
So we will counsel and then accordingly we will decide.
She returns in 1 year. Her PAP is LSIL, HPV positive. What is the next step? Dr. Sapna, this question is for you.
Yes, ma'am. Am I audible, ma'am?
Yes. Yes.
If the cytology turned to LSIL and she is HPV positive, then next we have to do the colposcopic evaluation. And if in the colposcopy she is negative for CIN, then repeat cytology is to be done after 6 to 12 months. And if it is still negative, and we have the 2 negative reports of the cytology, then we do only routine testing. And if it is positive for the CIN, then manages according to ASCCP guidelines, that is for the CIN1 is observation only. And for CIN2 and CIN3 is the excisional procedure is better than ablative procedure.
Okay, Dr. Sapna, very well said. So if you are the patient is keeping on the observation, if during follow-up, any of the test is abnormal, colposcopy is recommended. Next slide.
So thank you, Urmila. I think let's go to quickly the another case. And this is a very interesting case in the sense that there's many a times we may face this problem. 35 years old female, P2 plus 0 with 16 weeks pregnancy with previous 2 normal vaginal deliveries, has come for regular antenatal checkup. There was a history of vaginal discharge and pain in abdomen. So perispecular examination was done and bizarre vessels were seen. Her pap smear was taken. The report has come to be HSIL. And so, Dr. Kiran. how to proceed now. She is pregnant. She has a report of HSIL.
Yes, madam. If pregnant lady is positive with HSIL, colposcopy can be performed and biopsy can also be taken from the affected areas because it is safe in pregnancy. But endocervical curettage is not indicated and ablative procedure as such late bone biopsy all are not indicated and is postponed up to 6 weeks postmortem. Colposcopy in pregnancy should not be repeated before 12 weeks. And you have to take into consideration, should not confuse, because in pregnancy most of the times there is ectropion physiological and you should not be confused with the abnormal finding during pregnancy.
Correct. So, Dr. Parul, will you tell her when actually biopsy should be taken in pregnancy? Because as Dr. Kiran said that she should be kept under observation and the colposcopy is done and the next time in other trimesters. So when what are the specific conditions when you would like to take the biopsy?
Ma'am, is in this patient, she is having HSIL, so colposcopy, and then depending upon the colposcopic findings. So because if it is high grade, because this is high grade cells, if it is histological HSIL, that is CIN2 or CIN3, or adenocarcinoma in situ is suspected, then we do this colposcopic guided biopsy. And if it is diagnosed, now surveillance colposcopy and biopsy, they are recommended, not biopsy, surveillance colposcopy is recommended every 3 to 6 months according to ASCCP 2019 guidelines. But they say that it can, if it can be deferred, next colposcopy, if it can be deferred, it should be done postpartum, but it will depend upon the conditions of the in the present pregnancy. If the lesion appears to be invasive and if the condition, if by the look it appears to be deteriorating, then we should do colposcopy.
Very rightly, because I mean, you can defer if possible. Spontaneous regression rates of CIN for pregnant patients are quite high, because many a times this pregnancy itself mimics like that, and progression to malignancy are low, even though we feel that the lesion is very significant or bleeding. They do regress, so we can wait for it. So Dr. Sapna, does pregnancy alter the progression of pre-invasive cancer lesions quickly?
No, no, ma'am. Pregnancy does not increase the risk for the pre-cancer lesion in cervix. But the physiological changes of cervix during
Sorry, आपका network बहुत अच्छा नहीं है. We have to move quickly. So just I will give you you have already given the point. The only thing which I would like to add is this colposcopy should always be done by the expert, because in the physiological changes of cervix during pregnancy may impact the likelihood of pre-cancer and cancer detection. So that's important. The residents or the newcomers will not be able to differentiate. This point should be taken in mind. So when to review these patients in postpartum, Dr. Amrita?
Ma'am, by the end of puparium at 6 weeks and then at 6 months, we will have a review of the reports.
Yes. So if patient is diagnosed HSIL during pregnancy, we can defer it and see in the postpartum period, and depending on the workup, we can do it.
If it persists, then we will proceed. Yeah.
Yes, yes. So Dr. Ubila, quickly take the case 4 so that we can finish and we leave the other cases.
The next case is Mrs. X, 36-year-old, para 1+1, presents as a new patient, no history of abnormal PAPs, last PAP 3 years ago, now sexual partner, new sexual partner for 6 months. Next slide. What is the preferred cervical cancer screening method? Question to Dr. Pragati Agarwal.
Yes,
Dr. Pragati.
Co-testing, yeah. Co-testing always it is preferred, like HPV and LBC or pap smear by liquid cytology. And if not available, then we can do only cytology.
So nowadays they are saying primary HPV testing is the most preferred one, and if it is coming to be positive from the same sample, they are doing reflex cytology. So to reduce the cost of testing, they are preferring primary HPV test. Since she is having a new partner since last 6 months, so she might be having a new HPV infection.
Very rightly said, Dr. Amrita. So the co-testing is preferred method, but the cytology can be acceptable. It is the 2019 consensus guideline. Now her PAP test report HSIL. Next slide. Dr. Amrita, question to you. What is the next
step?
Ma'am,
HSIL, the guidelines are now saying that if the report is HSIL, don't wait for colposcopy and biopsy, immediately move towards the treatment, excisional treatment in the form of LEDs. What is the new guideline 2020 saying? But ma'am,
so for doing excision, you need to locate the lesion first. The only the
why मैं कह रही थी आगे मैं यही कह रही थी what the clinical experience say, because many times HSIL may have SIN3 as well as a foci of the microinvasive carcinoma. So it is always better to have a colposcopy and biopsy of that area. If it is showing only SIN3, then treat accordingly. If it is showing focus of micro invasions as well, so we will have to decide that way. We will have
Even
to have
we can go with the screen and treat approach as well, ma'am. We are doing the colposcopy. We can excise the complete lesion at that point of time. That is screen and treat in
so it depends the setup you are sitting in, well equipped, what kind of patient it is. So it depends. It is like that.
Yes, so you can expedite if you want.
Yeah.
If you feel the need.
In low resource setup, you can do it.
हाँ, जो नई गाइडलाइन कह रही है वो यही expedite and no need of colposcopy and biopsy.
But in this there should be HPV positive also. HPV positive.
HSIL is the HPV positive. Usually HSIL is associated with HPV positive.
Do expedited treatment.
So her HP shows CIN3. What is the management of this patient, Dr. Priyanka?
Ma'am, we have already discussed CIN3. So screen and treat in the same setting, that is excision, complete excision of the whole lesion, which you see.
Now, immediate diagnostic excisional procedure is indicated, but there is a observation is acceptable with the co-test HPV testing and colposcopy at 6 months and 12 months, provided entire squamocolumnar junction is visible and on colposcopy and ECC is negative. Next slide. The choice of excisional procedure or observational should be taken into account patient desire, patient's preference, ability to compliance. Compliance is more important, that she is ready to follow up, and future childbearing plans. Next slide. So when observation is chosen, colposcopy and co-testing should be done at 6 months and 1 year. If the negative, then the HPV testing is recommended clearly. Long-term surveillance is required. If any test is abnormal during observation, repeat colposcopy is recommended and the diagnostic excision procedure is advised. This is the recommendation of 2019 ISCCP.
I think, thank you, Dr. Urmila, but I think we'll leave this case 5 and finally we'll just go ahead with the final the recommendations as Dr. Amrita just
ना 5वां केस भी 10 मिनट
बस आप बता दीजिए पोस्ट मेनोपॉजल
5वां भी कर लीजिए ना
मैम आप ही बता दीजिए बस
अच्छा नहीं ठीक है
5वां कर लीजिए
ओके
10 मिनट लगेंगे
okay yes, so Mrs. Y, postmenopausal female, P6+1, all FT and NVD came to gynae OPD with chief complaint of foul smelling vaginal discharge. Per speculum examination shows hypertrophied cervix, mucoid discharge, and the pap smear report is AGCFN, atypical glandular cells favoring neoplasia. What to do? Kiranji.
Yes, madam. Initial management will be colposcopy guided cervical biopsy, endocervical biopsy, and endometrial biopsy also. And we shall also go for proper imaging by 3D, TBS ultrasonography, or if needed MRI, to rule out ovarian, fallopian tube pathology, especially malignancy. This is in short.
Yeah, so basically endometrial sampling is added, and depending on the finding, then you go ahead with the other investigations. So if endocervical pathology comes positive, then what to do? Parul.
Ma'am, in this, first I would like to add that even if colposcopy is negative, then too we have to go on to the excisional diagnostic excisional procedure. And if the diagnostic excisional procedure, if the margins are negative, then we go on to hysterectomy. And if the margins are positive, then we have to again do this positive. Then again we have to do excision, and then that is preferred, and then we go on to hysterectomy. So that is according to the ASCCP guidelines.
Yeah, according to ASCCP guidelines, although personally, I think we all feel in this age group, we can straight away also go for a hysterectomy, because that is the age when we don't have to consider for a pregnancy or anything. So the only, with this, thank you all the panelists. These recommendations were ASCCP management guidelines, and the key, we tried to discuss the key changes. And basically the thing is that now the risk is determined by the prior history as well as screen results. And these tables have also taken into address the unknown history scenario also. So now the result based, say, it has shifted to risk based, and on that basis we go. We'll not go into detail of this. Observation, jo Dr. Amrita, practically you have told very correct points, but as per guideline, CIN 1 may observation we can do up to 2 years, surveillance method say, and very rightly pointed out by you कि 25 years, और अगर life expectancy में problem नहीं है तो even more than 25 years we can do it. And there are certain conditions jahan pe we can expedite the treatment without doing any other thing. Whenever there is a risk, CIN3 risk is more than 60%, or even acceptable one like 25 to 60% के बीच में भी हम कर सकते हैं. The HPV 16 positive HSIL cytology, or those जो कि कभी never screened or rarely screened, or HSIL regardless of HPV genotype.
Yeah, ma'am. That is what I was saying.
Yes, we can expedite. That is what I know what you were saying. So that's why I can.
बहुत कुछ change कर दिया है. अभी मैंने पहली बार इस पैनल के बहाने पढ़ा तो मैंने देखा कितना कुछ change कर दिया है.
ये वाली guidelines हम अब पढ़ी, पहले कभी नहीं पढ़ी थी तो समझ नहीं.
हाँ, so these
2020 guidelines.
So key changes I wanted to highlight, and thanks again to Dr. Urmila and the panelists, and we will cut again, save the time and hand over the mic to our
I just wanted to share one experience.
All panelists for their wise inputs. Thank you.
And if you allow me, I would just like to share one of my experience. अभी just recent 1 minute का सिर्फ मैम.
Okay, sure.
Ma'am, the pap smear showed HSIL, biopsy showed STIN3 with suspicion of microinvasion. But मुझे लगा कहीं ऐसा ना हो कि invasive carcinoma हो, हम लोग सिर्फ hysterectomy कर दें इसकी. तो मैंने उसका CT scan कराया तो they showed lymph nodes positive, pelvic lymph nodes, subcentric, less than 1 centimeter. So we performed modified radical hysterectomy. So all the lymph nodes came to be negative, but the specimen showed a microinvasive focal microinvasive carcinoma. So many a times STIN3 is being reported, and actually she is a microinvasive carcinoma. So before proceeding for simple hysterectomy, get a CT and MRI done to locate the lymph nodes as well.
Now, actually, of STIN3 also depends upon how the biopsy has been taken.
Yeah.
If you take a superficial biopsy, you'll always miss those micro-invasive things.
And sometimes the area you are getting biopsy done, the other area is harboring micro-invasion. So that is also.
There comes the Amrita, there comes the role of good colposcopy.
Yeah,
very good colposcopy, then you can understand each and every step and kahan se exactly na hai, kitna depth hai, and the endocervical sampling is key importance bhi yahi pe hai, because then you will know the depth. So if you, that is what was the basic key messages, that if you do all those things, a date with colposcopy is important in this only. So, finally, and Dr. Priya has very, very wonderfully explained everything. So now I hand over the mic to coordinators for the poster and the session.
Thank you so much, Kiran ma'am. Thank you, Urmila ma'am. And thank you all the esteemed panelists for your valuable inputs. और इसी बहाने हम सभी ने in fact 2019 की गाइडलाइंस पढ़ ली.
Yes, exactly.
मुझे थोड़ी बहुत डांट भी पड़ी है.
Cross स्वीट हो पाविका, डांट खाती रहती हो, काम करती रहती हो।
पाविका वो डांट जो है ना,
उसी को डांट पड़ती है।
नहीं मैं मुझे पुराने दिन याद आ गए अपने
डांट नहीं है, ये आशीर्वाद है पाविका, ये आशीर्वाद है, डांट नहीं।
पाविका, प्रतिमा, दिव्या, अलग है।
किरण, मैं एंडोर्स करती हूँ कि पाविका बहुत स्वीट है।
जी मैडम, जी मैडम।
मैडम हम लोगों को भी स्वीट कर दे, कह दो ना।
नहीं शीला, किरण किरण
मैडम।
क्या बात कर रही हो तुम, तो भैया बस मेरी अपनी हो बिल्कुल। पाविका को तो मैं इसलिए कह रही हूँ, इसने एक मेरा पेशेंट इतनी अच्छी तरह उसकी केयर ली थी कि वो बात तक, किरण बॉम्बे गई हुई थी तो वो
जी
बात
मैडम,
तक
मुझे याद है।
पाविका की तारीफ करता
ये
था।
बात तो है मैडम। आप मेडिकल कॉलेज में कोई केस भेज दीजिए, इन लड़कियों को कह दीजिए डॉक्टर सब पूरा देती हैं बकायदे कि ये अब ये हुआ मैडम, ये हुआ।
दैट इज रियली क्रेडिटेबल।
डॉक्टर किरण सिन्हा, इसमें थोड़ा सा क्रेडिट जो है ना वो मुझे कि ये सारे मेरे बच्चे हैं और ये सब मेरे
वो तो है ही है क्या? वो तो आपका है। अब आपको इतना डिस्टर्ब नहीं कर सकते ना, बिकॉज यू आर
अच्छा किरण, अब मुझे छुट्टी दे दो भाई, बहुत बढ़िया पैनल डिस्कशन है।
डिस्ट्रीब्यूशन मैम बस 5 मिनट का है, प्राइस डिस्ट्रीब्यूशन मैम
अच्छा,
केवल 5 मिनट, जल्दी से
बहुत
करो,
ज्यादा टाइम नहीं वेस्ट करूंगी। मैं सपना मैम को माइक हैंड ओवर करना चाहती हूँ प्राइस डिस्ट्रीब्यूशन के लिए। सपना मैम, सपना मैम।
थैंक यू पाविका। हाँ हाँ पाविका, थैंक यू पाविका।
आवाज आ रही है, आपकी आवाज आ रही है।
Now the most awaited movement of the today's webinar is the announcement of the results for poster and slogan. And the topic was prevention and screening of cervical cancer. And our judges are Dr. Seema Hakim ma'am from AMU and Dr. Sujata ma'am from KGMU. Can I have the CV of Seema ma'am?
बेटा we all know it, बस आप प्राइस के बारे में बताओ।
सीमा को कौन नहीं जानता?
Can I speak now? Please don't show the CV. Unnecessarily we'll be wasting time and we'll be holding all the participants. So
Dr.
good
Seema
evening,
announced
all
the
esteemed
result.
participants
Dr.
of the
Seema and Dr.
workshop.
Sujata.
I have started speaking because otherwise you will show the CV. There was no need.
नहीं बिल्कुल।
Thank you, Professor Kiran Pandey, for giving me this opportunity. It is always an honor to be a part of some activity of UPCOG, and I am honored that Professor Usha Sharma ma'am is there and we all love her so much. So before we go on to the result, I would like to give my feedback about what we got for the poster and for slogan presentation. So there was a sincere effort made by all the participants, and many, they participated in the event. And I must tell you that there was really sincere effort in consulting Dr. Google in a very efficient manner. So what we both felt, Dr. Sujata and me, both we felt that some originality was missing. So if some original idea should have been there, what if it was small? We would have really loved it. So whatever was available to us, we have judged from that, and we tried to take out best from what they have submitted. So for this, I'll request Dr. Sujata Dev to announce the result of the winner of both poster and slogan, and I would like her also to give her feedback.
Yes, ma'am. Thank you, ma'am. Seema ma'am. Definitely poster and जो slogan थे, that was the great. But definitely there is some थोड़ा सा कहीं ना कहीं जो अपनी originality होती है वो थोड़ी कम थी. Especially क्योंकि इतना easy होता है Google से शायद cut paste करना या ये करना और time short होता है. ठीक है, but beside that अच्छे poster बने, अच्छे slogan थे. And we Seema ma'am से discuss किया and we judge according to the जहाँ originality and which is the focused point which we kept in the either in the slogan and वो. तो first of all मैं खुद तो poster के लिए कहूँगी, लेकिन slogan के लिए मैं सीमा मैम से request करूँगी कि आप करिएगा. तो first consolation prize for the poster, that is the goes to the Gauri, Dr. Gauri Kitali from the BRD Medical College. And you can see that she also included all the points which are required for the screening, what is the treatment, HPV vaccine, when to consult, what is the screening method. So keeping all these things, and she wrote as the HPV vaccination is the key. So the next prize, third prize,
Congratulations, Dr. Gauri.
Dr. Gauri? नहीं है.
Okay, चलो आगे चलो.
Prize goes to the Dr. Jagriti from the sorry.
Dr. Komal Sachdeva.
From the MLN Medical College, Prayagraj. And she also included all the important points. What are the preventable methods? What are the basically what are the signs and symptoms? What the methods? How to detect? What are the risk factors? So that gives the very good message that stay strong and let's beat cervical cancer. That is very, very important.
Congratulations, Dr. Komal.
Congratulations, Dr. Komal. Next. Second prize goes to the Dr. Jagriti. And why we decided this? Because the important thing, जो हमारे यहाँ का कि fourth most common cancer in the woman, and कितनी deaths होती हैं, और what is important that how to do the screening, what are the age, कब उसको करना चाहिए, और जो important है कि how to prevent it, that is the Gardasil and Cervix जो भी है, what कब कर देनी चाहिए, तो that included all in the one, that is very, very important. So congratulations, Dr. Jagriti. Next. And Dr. Anita Gautam has compiled to the point. That is excellent. The poster not for us, for the public. Basically, क्या important है कि एक बार देख के कुछ हम अपने आप में grasp करें. तो उन्होंने इसने तो बहुत अच्छा कि to the what are the methods for the prevention of the cervical cancer, vaccine yourself, screen yourself. What are the signs and symptoms? So I think this is the very concise, to the point, no थोड़ा originality जैसे हमें step. So congratulations, Dr. Anita.
Congratulations, Anita. We are.
Congratulations, Anita.
I mean, finally कुछ तुमने कानपुर को इज्जत रखी.
नहीं, उसने बहुत.
Anita has joined. Anita, congratulations. She is always very active. हमारे यहाँ medical officer में, family planning में, and does wonders.
Thank you, Seema ma'am, and thank you, Sujata ma'am. Jagriti and
actually, we are showing all the posters so that the judgment is very crystal clear. I don't think. Yeah.
Seema, when you are there on the panel, nobody can say even a single word about your judgment.
Thank you, ma'am. I'm really honored.
नहीं, सुजाता और तुमने इतना अच्छा काम किया है. It's, you know, it's a thing where, and I totally agree that you should have your own creation. Yes. Actually, we should not copy from the Google. That doesn't give a good effect. Yes. So in future, if we have any slogan competition or any poster competition, we should, I think we can add a line that it should be your own creation. Yes, if it is possible.
Yes, madam.
Yes,
because madam. That's a good
originality.
Yes, you can just put a line there so that if they have got a very good slogan and they don't get the prize, then they can understand, oh, ये मैंने Google से copy किया था इसलिए मुझे नहीं मिला. तो ये एक message जरूर जाना चाहिए. हम कोई भी competition रखें.
Yes, madam say slogan का copy है.
Slogan के लिए सीमा मैम please.
नहीं, सुजाता, carry on.
Yeah. So for the slogan, I think Dr. Sapna, please show. And slogan आपकी जो किरण मैम, आपकी जो अनीता गौतम है, डॉक्टर अनीता गौतम है, उन्होंने फिर उसमें फर्स्ट प्राइज लिया है.
Oh my God. अब तो हम लोग अनीता से कल पार्टी लेंगे, बड़ी वाली.
तब तो फिर पार्शियलिटी हो गई.
नहीं मैडम, मुझे तो कुछ भी नहीं पता है.
No, I'm just joking.
मैम honestly speaking, मुझे किसी ने कुछ नहीं दिखाया है, मुझे बिल्कुल नहीं पता.
नहीं, अरे मैं तो I'm just joking.
जी मैडम.
जरा जल्दी बोल बोल दे यार.
जल्दी दिखा दीजिए प्लीज डॉक्टर सपना. अच्छा कोई बात नहीं, हम बोल दे रहे हैं.
नहीं लगा हुआ है शायद, ये कॉन्सोलेशन प्राइज लगा है.
कॉन्सोलेशन लगा है.
अच्छा अच्छा. फर्स्ट दिखा दीजिए, अब बोल दिया तो फर्स्ट दिखाई दीजिए. हाँ
चलो. हाँ,
ये फर्स्ट प्राइज दैट इज बच्चेदानी से खून या गंदा पानी हो सकती है कैंसर की निशानी, समय रहते डॉक्टर को दिखाएं, पैप स्मीयर की जांच तुरंत कराएं.
वेरी गुड, गुड वन.
ये बहुत ही अच्छा था. मुझे तो लगता है कि ये हमें भी अपने ओपीडीज में लगा देना चाहिए. मतलब
वेरी ट्रू. यस यस.
सेकंड
प्राइज गोज टू डॉक्टर प्रतिमा वर्मा एंड बहुत ही मतलब कि कीपिंग द लेडीज ऑफ द इंडियन सिनेरियो और इंडियन वुमेन, जो कि उनको देखते हुए रखा है. मुझे लगता है कि ना ही घबराना ना ही शर्माना, सब सखियों को है बताना, सही समय पर डॉक्टर से चेकअप करवाकर सर्वाइकल कैंसर को है हराना.
वेरी गुड, कांग्रेचुलेशन प्रतिमा.
क्योंकि दिस इज द वन वेरी इंपॉर्टेंट कि हमारे यहाँ की लेडीज दे आर नॉट कमिंग आउट एट द राइट टाइम, सो दे आर सफरिंग अ लॉट फ्रॉम द सर्वाइकल कैंसर. एंड थर्ड प्राइज गोज टू डॉक्टर सुभी विठल वरियानी फ्रॉम द GSVM कानपुर.
शी इज फ्रॉम प्राइवेट प्रैक्टिस कॉक्स में कानपुर.
ठीक है मैम. डरना नहीं डराना है, हारना नहीं हराना है, सब्र का इम्तिहान लेती है यह बीमारी, समझना भी है और समझाना है, लक्षणों के प्रति सदैव सचेत रहे, सर्वाइकल कैंसर को मिलकर भगाना है.
वेरी गुड, कांग्रेचुलेशन सुभी, कांग्रेचुलेशन.
So it was Dr. Pratima, assistant professor, second prize.
Yes, I think it is because it has not written.
Oh, हिंदी की तारीफ हो रही थी, हिंदी को आपको अवार्ड भी मिल गया आपके.
She deserves that.
एक कॉन्सोलेशन भी था शायद.
हाँ, कॉन्सोलेशन.
ये इसमें थोड़ा सा अच्छे से दिखाओ, जो लास्ट वाला था बैटल वाला. इन्होंने असल में कई उसमें भेज रखा था, ठीक से आ नहीं पा रहा ये. अदरवाइज गेट योर पेप स्मीयर, डैप द फियर, सर्वाइकल कैंसर इट इज प्रिवेंटेबल एंड क्यूरेबल. एक्चुअली में स्लोगन के लिए बहुत कम आए हुए थे मैम. डिफिकल्ट कि क्या हम करें, तो थोड़ा सा पर्सनैलिटी और थोड़ा उसको
लास्ट में लिखा है जस्ट अ स्क्रीन टू नो द अनसीन.
यस
दैट वाज अ
कांग्रेचुलेशंस डॉक्टर जीवा.
गुड.
यस मैम. So thank you Usha ma'am and the Kiran ma'am who giving this opportunity. और सीमा मैम के साथ तो बड़ा मजा आया.
Thank you Sujata for such a good presentation. You have summed up everything so well.
डॉक्टर सीमा को जो कह दिया जाए वो बहुत सिंसियरली
होता है.
परफेक्ट. इसीलिए तो मैडम मैंने एक काम
क्विज मास्टर कहती हूँ, हमारी क्विज मास्टर है. और सारी चीज बहुत सिंसियरली करती है.
Thank you ma'am. Thank you.
So Kiran, I must really congratulate you. You are such a devoted, dedicated and such a sincere person that you have organized this webinar so well, and no doubt this is a very important subject for our day-to-day practice. Unfortunately, in spite of the fact that it is a preventable disease, we have not been able to eradicate it. And then as I said, let us join hands to just eradicate it and let our dream of cervical cancer Mukt Bharat come true. And I say that let us also fulfill the targets by completing cervical eradication by 2030. Thank you very much, Kiran. I must congratulate you and your whole team. You have done a really wonderful job, and I appreciate that so many persons could take part in this. But the only thing which I told you, Kiran, that we will like to limit the program for about 1.5 hours.
Next time, madam, I'll keep it in mind.
I agree. No, it's not for you, Kiran, for everybody. Because if it is a program for about 2 hours or more than 2 hours, so the interest of the audience goes. And that's why I always prefer that either we should have only panel discussion, because in panel discussion you can involve 7 or 8 persons and you can have the detailed discussion of the subject. So you can, I think you can deal with every item of the subject if you have only single panel discussion. You do not need a talk as well as a panel discussion. So
Right,
I will
madam.
just put in the group also. But
Right,
whatever you have done, it was a tradition. We were doing it like this. But I must congratulate you and your whole team for wonderful organization. And I really wish all the chairpersons a very, very bright future, and I am sure that you all will contribute a lot towards these UPCOG academic activity.
Definitely.
Thank you very much.
Namaste, ma'am. Namaste.
Hello,
Ma'am,
Bharti.
Hello,
Congratulations, Kiran ma'am. बहुत
तू
अच्छा
तो बहुत
प्रोग्राम।
स्ट्रॉन्ग पिलर है। मैं तो शुरू में ही कह रही थी, पर वो कुछ ऐसा हुआ थोड़ी देर के लिए। एक तो आज हमने और किरण ने बड़े जबरदस्त ढंग से करा था, शॉर्ट करो, तो मैंने सबसे पहले तो अपना ही शॉर्ट करा, फिर लगता है शॉर्ट करने में भारती को बुलवाना भूल गए।
नहीं, कोई बात नहीं मैम, आई एम ऑलवेज हियर एंड बहुत अच्छा लगा।
भारती ने थोड़ा सा शायद लिंक आपको कुछ लिंक में देर हो गई थी ना, ये भी
नहीं, I was till 5 PM and I have shared all photographs in your group. तो मैं
अच्छा, पता नहीं, मुझे भी नहीं दिखी थी शुरू में। And we must thank Mr. Ranjit Sahu. He has really done a wonderful job, and without your cooperation, I don't think we could have such a wonderful webinar today. Thank you very much.
Thank you, doctor.
Okay.
Thank you. Bye. Good night.
Thank you.
Question I want to ask, ma'am.
Sure, ma'am.
For such kind of scientific conclave.
दिव्या, आप ऑफिशियली थैंक्स बोल दो सबको एक बार लाइन से।
Yes.
दिव्या जल्दी बोलो फटाफट। थैंक्स
बोलो दिव्या।
रह गया।
I want to thanks to all the dignitaries here for sparing their precious time and gracing the occasion. Thank you, ma'am. Thank all of you. Thank you, ma'am.
Yes, short and sweet. Short and sweet. Okay.
Thank you, Sujata.
Thank you, ma'am. Thank you,
Thank you, Urmila. Thank you.
किरण, एक चीज सुनाऊंगी यहाँ। एक बार एक आदमी स्पीच देने जा रहा था स्टेज पे, तो उसकी वाइफ ने एक कागज में लिख के भेजा KISS। सबने कहा भाई इसकी बीवी तो बहुत ही अच्छी है, जो इवन ऑन द स्टेज शी इज सेंडिंग किस। तो उसने कहा नो, मैं लिखना चाहती हूँ कीप इट शॉर्ट एंड स्वीट।
दिव्या पे पूरा लागू हो रहा है।
Yes. Okay, good night.
बड़ा सा था लेकिन बोला दो लाइन।
Thank you, madam.
Thank you, ma'am. Thank you. Have a lovely evening ahead. Stay healthy.
Thank you, Ranjit. Thank you.
Thank you, Seema ma'am. Namaskar.
Thank you, ma'am. Good night, ma'am.